Welcome to our first Kingston Myeloma Canada InfoSession. Thank you for coming out on this beautiful Saturday morning. I'd also like to welcome all the viewers across the country and I guess around the world that are tuning into our webcast. This is being webcast live. And for those of you at home, you can send us questions. You see on your screen to the right. Just click on questions and you can send us questions and we will, time permitting, be able to ask those questions of our panelists here today and as here as well. If you have questions, please make sure to note them down on a piece of paper and we will get to them throughout the course of the info session. Before we begin, I would like to extend a deep felt thanks to our partners here, the Kingston General Hospital and the Southeast Regional Cancer Program, without whose tremendous help and support we would not have been able to put on this program this morning. Additionally, I'd like to thank our two pharmaceutical sponsors, Celgene and Janssen, without whose financial support clearly we would not have been able to put on this info session. So thank you very much for all your help and support. Before we begin, I'd just like to spend a couple of minutes talking about Myeloma Canada. I assume most of you are aware of who we are. We are the only patient organization in Canada exclusively devoted to the Canadian myeloma community. It was founded a little over 11 years ago by myself and a fellow patient, and it remains to this day a very patient-focused and patient-driven grassroots organization. And we're very much committed to improving the quality of life of all Canadians living with myeloma, as well as their families, through our four pillars, which are education, and today is an example of the type of educational initiatives we do. Awareness, as you know, myeloma is not a very well-known disease, so we do our best to create awareness around the disease and make sure people understand it's myeloma and not melanoma. Increasingly, we do a lot of advocacy. As many of you know, I'm sure we have this year, we're blessed with five new drugs that will be potentially approved by Health Canada, which is amazing. This is seriously an amazing year for the myeloma community. However, just because the drug is approved doesn't mean patients have access to it, because these drugs, if you don't have private insurance, are funded by the provincial drug programs. And that's when the real work begins at the grassroots level, advocacy efforts, both nationally and provincially, to ensure that our governments find the money to fund these life-saving drugs. So you'll be hearing a lot from us in the coming year and next year on the issue of advocacy and access to new drugs. I'll be speaking a bit later on this morning on what we're doing in the area of science and research. And all of these together combined is really distills our vision of creating a world where myeloma is no longer a fatal disease. And I can say, having lived with this disease for 14 years, we've made tremendous progress, especially in the last 10 years when way back in 2002, we essentially had some very blunt tools to deal with the disease, the melphalan, the steroids, and today, as I mentioned, we have 5 new drugs potentially being approved this year with Health Canada, which are much more targeted, much more specific, less side effects. So we certainly have come a long way in getting towards this goal of perhaps not maybe finding a cure tomorrow, but making this disease a chronic disease. I'd also like to point out, for those of you who are not aware of our educational resources, we do have a patient handbook as well as a booklet on understanding your blood and blood tests. Very important you understand that, as well as a booklet on myeloma bone disease, and they are available just outside the meeting room here on the table. So please feel free to help yourself. I also want to highlight some upcoming educational events. This is the first in a series of educational events for 2016. Our annual conference is coming up very quickly next month, May 14th and 15th, in Montreal at the Hyatt Regency. It's a 1.5-day conference, And you can, if you're interested in attending, you can register online on our website at myeloma.ca. And for those of you listening in from across the country, we will hopefully be coming to a city near you in the coming months: Winnipeg, June 4th, Quebec City, July 9th, Windsor, August 13th, and St. John, New Brunswick in October. And some of these will be webcast because we do understand not everybody can come to these sessions live, either due to health concerns or distance. So, on with today's program. There'll be 4 speakers today. Starting off the program this morning with Dr. John Matthews, who'll give us a bit of background on myeloma, as well as talk us through the whole stem cell transplantation and talk about some of the drugs that are being used to treat myeloma. This will be followed by Leslie Weatherby, who is a myeloma patient herself, and she'll be sharing her own personal myeloma journey with us. After the break, I'll come on and give you an overview of what Myeloma Canada is doing in the area of research and clinical trials. And we'll round out the morning with Dr. Annette Hay, who will be giving us a very interesting talk on myeloma clinical trials, past, present, and future. So now I'd like to call upon Jessica Holmes, who's been very instrumental in helping us organize this meeting today, to give us a few housekeeping details. Jessica?
Hi, everyone. Welcome. My name's Jessica Holmes, and I'm a patient educator at Kingston General Hospital. It's great to see so many familiar faces here today. So we just wanted to welcome you on behalf of our organization and also Myeloma Canada. I just wanted to say a couple housekeeping things before we get started. The washrooms, as I'm sure most of you know already, are on the right-hand side here outside of the auditorium. So if anyone needs to use the washroom, those are where the facilities are. There's breakfast out in behind the auditorium, so if anyone likes to go up and get some more to eat, then there's stuff there, and the refreshments will be replenished during break. There's also, if anyone wants to get breath of fresh air, there's a courtyard behind where the catering is. If anyone wants to go out to the courtyard after break, then you're welcome to do that. We have a number of volunteers here that have helped to put on the event this morning. Most of them are nurses who you probably recognize, so if you have questions, you can ask myself or the ladies at the registration desk or any of the nurses who you may know from previous experience. One quick thing about questions. So we encourage questions after the presentations. If you do have a question, I just request that you raise your hand because we'd like to be able to use a microphone so that we can hear your question both for the webcast and also in the room. And Shanika at the back of the room will bring the microphone to you. So we'll do that after the presentations, after each presentation. So without further ado, I am going to introduce our first speaker. Our first speaker is Dr. John Matthews. He's a hematologist here in Kingston. Dr. Matthews holds rank as professor in the Division of Hematology at Queen's University. Initially, he was involved with laboratory research into the cellular effects of vitamin B12 deficiency, and he spent most of the last 20 years in clinical work, teaching, and residency training. And we're particularly happy to have him join us here today because he said he's about 80% retired at this point, so it's lovely to have him join us here, and I'm sure most of you and many of you know who he is, and so I am happy to have him come up, and I'll just pull up his slides here.
So thank you, Jess, for that kind introduction, and welcome to everybody, and it's nice to see quite a lot of familiar faces. I was asked to talk about myeloma to try and give you an idea of what the disease is and what it does to you, and I'm going to do that, I hope. I was working out that it's 38 years since I gave the first talk on multiple myeloma to medical students, and it was a total disaster, I have to say. I had trouble learning about multiple myeloma when I was a medical student because it was so complicated. And trying to teach it to medical students these days is actually a complex problem, and they often don't quite get it. So I'll try and pitch this at a level that you find intelligible. If you don't, you can ask questions afterwards. So I'm going to talk about multiple myeloma, and then I'm going to talk a bit about stem cell transplant. So in order to understand multiple myeloma, you have to understand the production of antibody. Normal immunoglobulin production. I wonder if there is a pointer. Jess, does anybody know? You want me to? Okay, yeah, okay. I'll do without. So on the left is a plasma cell. It's got the round bit in the middle is the nucleus. And its job, it's a normal cell, it lives in the bone marrow, and its job is to produce antibody. And that thing on the right that looks like a dinner fork is an antibody molecule. It's made of protein, and I'll come back to its structure later because it's important. Just to give you some idea of the scale, though, because the plasma cell looks quite large there. If you put plasma cells on a pinhead, you'd get 20 of them. But lining them up end to end until you got to the other side, you'd need nearly 63,000 antibody molecules to cover the same pinhead. So the antibody molecule is very small. So the plasma cell makes it, and it releases the antibody into the blood. And we all have plasma cells, and we all have antibody. So if you get a cold, for example, you have to get rid of the cold virus, and the way you do that is you make antibody to the cold virus, and the way you do that is you make more plasma cells that make antibody to the cold virus. And so you accumulate larger numbers of plasma cells, and they secrete more antibody into the blood. And then that kills the cold virus. What's important to realize, though, is and it'll be important later, but each antibody molecule is a little different from the next one. The cold virus has a number of different things you could target on it, and the antibodies tend to target different pieces of the cold virus, for example. Just imagine this is a cold. It would apply to any other infection too. So the plasma cells make this antibody. Fine. And then the cold gets better. Fine. Takes a few days. And then when the cold's over, the plasma cells go away. And the amount of antibody you produce, I've called it IG here because IG stands for immunoglobulin, and immunoglobulin is the same thing as antibody. So if I use the word immunoglobulin, you could substitute antibody. The plasma cells go away. Well, how do they know they have to go away? And the reason is that they have built into the nucleus a genetic program that acts like a little computer, and it controls the cells. So when they're no longer needed, this little computer program switches the off switch, and the plasma cells go away and die. You don't need them anymore, they just disappear. And that's very important that they do that, because otherwise you'd have a whole bunch of useless plasma cells around the place, which could damage you. So that's what happens normally. You make plasma cells when you need them, you get rid of them when you don't need them, you make antibody when you need it, and you stop making antibody when you don't need it. So what happens in multiple myeloma? So here's your plasma cell again, and it's got a big crab in the middle to indicate that something bad has happened to the nucleus. What has happened, in fact, is that the little genetic program in that plasma cell has lost the ability to control it. It can't switch it off anymore. Once it gets on, it just carries on. It just carries on going, and you can't get rid of it. So you've got a permanent plasma cell, and of course, it does what it was originally designed to do. It makes antibody, and so you've got permanent antibody production. Okay, so it's as simple, if you like, as that, or as complicated. It's a very complex mechanism, ultimately, when you get down to it. So there's a switch gone wrong in the plasma cell, makes it permanent, and so you have the permanent production of antibody. So in the beginning, this happens in one plasma cell, somewhere in your body. And that doesn't matter too much, because one plasma cell, who cares? I mean, you've got gazillions of them. But as time goes by, you get more of them. And the thing to remember about these plasma cells is that unlike the plasma cells that you make when you've got a cold, all these plasma cells are identical because they're all the progeny of that original cell that changed. So all these plasma cells are identical. And the antibody, because of that, because one plasma cell makes only one type of antibody, once you've made your plasma cell, it can only make one type of antibody. All the antibody molecules you make from those plasma cells are identical. So you've got a whole bunch of pretty useless plasma cells and a whole bunch of pretty useless antibody. And as time goes by, that gets worse. You get more and more plasma cells and you get more and more antibody. So the thing about multiple myeloma is then you have two problems. You have a tumor problem, so that's the cells, that's the plasma cells, and they cause trouble. But unlike other cancers don't do this, the plasma cells produce the antibody. So you have an antibody problem too. So you've got, and that can separately cause damage. So you have a tumor problem and you have an antibody problem, and they can, and because of that you have different clinical effects. And I'm going to show you some of these effects right now. If you're a little squeamish, you might want to block your ears or something, or shut your eyes, because I'm going to show you some specimens and some X-rays of some of the pathological effects of multiple myeloma. So I don't want to shock you, but it does make the point about myeloma, I think. So we'll kick off with a tumor. Normal plasma cells live in the bone marrow. And so that's where the effects of myeloma are principally centered. And this on the right is a picture of a spine, a human spine. It's an autopsy specimen, and the spine has been sliced down the middle. And the white bars that you can see across are the discs. So those are the normal discs between what are called your vertebral bodies, which are kind of stacked up one on top of each other with discs in between. And the reason it's so red is that you have red marrow in your vertebral bodies. It's quite normal. It's where your blood is produced. And so if you take a spine and slice it down the middle, it looks like that. It looks red. But there's something wrong with this. You can see where the arrows are. There's a couple of gelatinous blobs. And actually, if you look closely, there are there's quite a number of smaller gelatinous blobs. Those are what are called plasmacytomas. Those are collections of plasma cells, plasma cell tumors inside the bone marrow. So this is multiple myeloma. You're looking at multiple myeloma, and that's why it's called multiple myeloma. A myeloma just means a tumor in the bone marrow, and this is multiple because there are multiple tumors. That's the way the disease got its name back in the 19th century. So now you're looking at multiple myeloma, you're looking at multiple tumors of plasma cells. And many of you will have had a bone marrow examination, I imagine. And so if you stick your needle into bone marrow, you don't usually use the spine, we'd usually use the hip. If you do it from a normal person, you pull out cells on top left there, and that's normal blood-producing cells. But if you look at the bottom left, you can see what we would pull out of a myeloma bone marrow. So there's an aspirate, and when you stain it, you can see plasma cells, nothing but plasma cells. So they look a little bit like the cartoon that I showed you, sort of blue fried eggs. And so doing a bone marrow examination helps us to diagnose multiple myeloma. Okay, so you've got tumors in your bone marrow, so why do you care? Well, one is you don't produce blood properly anymore because your factory doesn't work. It's full of plasma cells instead of being full of normal bone marrow cells, so you underproduce what you're supposed to produce. And mostly that's red blood cells. For the most part, that's what gets people the most. And so anemia, low red blood, is a very common consequence of multiple myeloma. I'm showing you a blood slide. This is what's called a blood film. So they've taken a drop of blood and put it on a slide and spread it and stained it. And just for your interest, although it's not really important, but the sort of orangey things on there are red blood cells. And normally speaking, when you look at a blood film, the red blood cells are separate, they're single. And you can see that these are stacked up, and they're fancifully stacked up like stacks of coins. And we call those rouleaux. So what you're looking at is rouleau on a peripheral blood film. And the reason for that is that there's too much protein there. And the reason for that is it's all antibody protein. So you've got a ton of antibody protein in this blood, and it's making the red cells stack as rouleau. It's just a helpful diagnostic feature. It's not harmful to have rouleau. Your body doesn't care. Now, the bones in you and I are strong because they have an outer bit that's hard and a middle bit that's got the bone marrow in it. So your leg bone, for example, is like a tube. And most of the strength comes from the outside bit, which is heavily calcified. The inside bit is connected with making blood, it's bone marrow. Well, one of the problems with multiple myeloma is that those little tumors cause activation of a bone-eating cell called an osteoclast. You and I, all of us have osteoclasts. It's basically a bone eater, it's a job. The bone-eating cells get really excited when they see myeloma, or when they're next to a myeloma tumor. So you begin to eat away your own bone. And I'm showing you here a skull X-ray. It's shot from the side. The patient is looking to the left there. And you can see that the hard bone is white. And where there are dark areas, it means the hard bone has been eaten away. And you can see in this skull that there are many areas in there where the bone has been eaten away. They refer to those medically as what they call lytic lesions. You may have heard the term, but it's just basically areas where the bones got eaten. I should point out at this time, though, that not everybody gets everything. Some people get awful bone disease and some people get none. And for reasons we don't really understand. And some people get lots of kidney trouble, some people get none. So it doesn't happen to everybody. The other thing about this, surprisingly, that looks pretty impressive, but they're not very painful usually, the skull lesions. People just don't really often know that they have them. But other bones in your body are a bit more critical. So this is a backbone. So you're looking at an MRI test now on a backbone. And the patient is facing to the left. And you can see the spine there. You can see the little vertebral bodies, the building blocks of the backbone. And you can see that there are little holes in those bones. And that's because there are multiple tumors there. Now, your backbone takes an awful lot of hammer every day. It's bearing your entire weight. You're bouncing up and down as you're walking. You're bending over and squashing the front. And so these myeloma tumors weaken the bone. And you can get what are called compression fractures, which I'll show you in the next slide. But back pain is a common feature in multiple myeloma, and that's because the bones are weakened by the myeloma. This is just a plain X-ray, which is actually a good way of looking for them, of what's called a wedge compression fracture. You can imagine, as you bend forward, your spine has to curve, and the front ends of the vertebral bodies take an awful lot of pressure. And if the bone is weakened, they just go whoop like that. And you get what's called a wedge compression fracture, and you're looking at that there. So you can see, this is again a picture from the side, and you can see the vertebral bodies, the backbones, and you can see where the arrow is, that one's got squashed, smaller than the others. It should be the same size as the others. And the squashing is more at the front. They call it wedge compression. Generally speaking, painful. Yeah. I'm going to come back to that. So and the other effects of weakening is on other important bones for you. So myeloma tends to affect the places in your skeleton where you have red marrow, which for most people is kind of down to about the middle of the shafts of the arm bones and the middle of the thigh bone. So you can get myeloma trouble in those areas too. And here's 3 X-rays of the same patient with a myeloma problem in the arm bone. So if you look at the left side, at the top you can see the shoulder joint, at the bottom you can see the elbow joint, and in the middle you can see an area that is kind of where the the hard bone bit kind of disappears. The outer bit, the outer white bit, gets very thin, and then you can see a discontinuous bit in the middle, and that's an actual fracture. And you can see it slightly better on the middle X-ray. You can see that the arm bone comes down, and then there's a sort of jagged bit, and that's a fracture. They call that a pathological fracture. It just happened because the bone was so weak. There was no injury, no accident, no trauma, no nothing. It just happened. And then the orthopedic surgeons have put down what they call a nail. I always wonder why they call it a nail instead of a rod, because it looks more like a rod to me. But that will strengthen the bone, and that actually restores function to the arm. So that's your bones. Just to continue with the tumours for a bit, if the tumour is, if you have a myeloma tumour in a very critical place, then it can cause trouble. And one of the problems, or one of the relatively common problems that we encounter, is when you have a tumour in your backbone that grows through and hits your spinal cord. And what you're looking at here is an MRI of a patient who's facing left, and you can see the vertebral column. I think I'm going to have to try and do this, yeah. So this thing here where the arrow is, the dark stripe, is the spinal cord. And the white stuff around it is the water that surrounds the spinal cord, so-called CSF, but it's kind of a liquid that surrounds the spinal cord. And here are the vertebral bodies, here. And as we come down, you see there's a problem with this one. And that's actually a myeloma tumor. And it's growing backwards, and you can see that the edge of the tumor is actually hitting the spinal cord. Now, the spinal cord is your main electrical connection of your brain with your legs, and so this patient had trouble with leg weakness, so because of spinal cord compression. So the tumors, depending on where they are, can cause trouble other than weakness in the bones. Spinal cord compression is one of the things we encounter not infrequently, and it has to be dealt with very quickly. Okay, and the last thing, if you've got a whole lot of tumors eating away your bones, you have a whole lot of calcium that you need to dispose of, and up to a point you can do that. But if the load becomes so overwhelming that you can't cope with it anymore, the blood calcium level goes up. And that's actually quite an important event. It causes trouble with your kidneys, it causes trouble with your ability to think, and it causes other things as well. So it's an important consequence of multiple myeloma. So, and they call it hyper, which means too much. Calcemia, emia means in the blood, calc means calcium. So that, if you translate that, it means too much calcium in your blood. Many of you will be getting permidronate or have had it, and that's a good way of controlling calcium. It does other things for you, but it's one of the ways that we control calcium. Okay, so that's the tumour. Now we need to come back to the antibody. And I apologize in a way for this because it gets a bit biochemical. This is, all antibodies are constructed like this. Okay, so they're what are called protein chains. And so an antibody has two heavy chains and two light chains. And the plasma cell makes all of this. So it makes the heavy chain, and it makes the light chains, and then it assembles them before it's released. And like I say, one plasma cell makes only one type of antibody. These heavy chains come in different flavors. There's the G type, and for our purposes, there are more than this, but for our purposes today, there's the G type of heavy chain and the A type of heavy chain. And if you have the G type, you make a molecule that we call IgG, immunoglobulin G or antibody G. Okay, and if you have the A type, you make IgA, immunoglobulin A or IgA. So since there are these different types in normal people of the antibody, it follows then there are different types of myeloma. There's the G type of myeloma, which I've shown on the top. So if you have a myeloma cancer that produces antibody G or immunoglobulin G, we call it IgG myeloma, and that's the commonest type. It's about 50% of persons have IgG myeloma. The next commonest would be IgA, and that's around about 25%. These are approximate figures only. So you have plasma cells that are IgA plasma cells. They produce IgA antibodies, so that's the second commonest. The third would be what we call light chain myeloma. So here's your antibody molecule, and it's heavy chains and light chains. So your plasma cells making both and putting them together. Sometimes when the genetic change affects the plasma cell, it loses the ability, either wholly or partially, to produce the heavy chain, and then it will produce only the light chain. And I should have shown these in yellow, but bottom right is meant to be free light chain. So about 20% of myelomas don't make G or A, they just make this free light chain. Okay, so those are the three basic types of protein in myeloma. I should add that even if you have the G and the A myeloma, quite often you'll make an excess of the free light chain as well. So so that you're aware of that. So why is that important? Well, first of all, it's important diagnostically. Right? We can look for these proteins in people that we suspect for having myeloma. And we do a test called serum protein electrophoresis, or SPEP. And you may have heard that referred to when you've been talking to your physician, perhaps. But I'm just showing you serum protein electrophoresis here. There's 10 different, this is a routine run from our chemistry laboratory. 10 different patients, right? 1 through 10. And in each patient, what they have done is taken blood, allowed it to clot, and taken the liquid bit called serum and applied it to this, what looks like a piece of paper, but is actually a thin layer of gel. Right? And what they have done for each patient is put on a dab of the serum where it says A, so round about here. And then what you do is you apply an electric current across that gel, and the proteins in the serum separate according to their electrical charge. So it's serum protein electrophoresis, because you're using a charge to separate. It's a very standard type of technique. So if we look at these, you can see across the top this protein here. That's albumin. It's negatively charged. Everybody has it, and it runs always at the top of the gel. So when you look at an SPEP, you'll always see an albumin band. When you look at the bottom, let's say we'll look at the bottom left, number 1, this area is called the gamma area, and that's where your antibodies run. Your antibodies run in this area here at the bottom. And that smudge indicates that there's antibody there, but because the molecules are all different, they all run slightly differently on this electrophoresis, and they give you a smudge instead of a discrete band. Right? So it's normal for normal people with normal antibody get a kind of smudge in this gamma region there. So as we go along, number 1's got a smudge, that's okay. 2's a smudge, okay. 3 and 4. 4's got a bit extra antibody. Maybe he's got an infection, we don't know. But it's still a smudge. 5 is missing some antibody and maybe having trouble making it. 6 and 7 and 8 are okay, but 9 and 10 are very different. There's a band there and there's a band there. That's called an M band. And it's often referred to as an M band. There are lots of different names for it. It's M for monoclonal. So M band, monoclonal protein, or paraprotein are all the same thing. And the reason that you have that band is that you've got a whole bunch of antibody molecules that are all the same. So they're all running in the same place. So that tells you that you have to have a whole bunch of plasma cells that are all the same. And that's highly abnormal. Normal persons don't have a bunch of plasma cells that are all the same. They're all different. But if you're producing what's called a monoclonal protein, you have to have what's called a monoclone, which means all the same, of plasma cells. So the presence of a monoclone monoclonal protein indicates the presence of a monoclonal plasma cells and indicates the possibility of multiple myeloma. So that's the importance of the monoclonal protein, at least diagnostically. It's important in terms of following patients too. So this is a patient I met first of all in 1999. He has IgG multiple myeloma. And so we can follow his course by looking at his IgG levels. His plasma cells are making IgG. He's got a ton of it. His level's about 80 grams per litre. The normal IgG level is up to about 16 or so, so he's got an awful lot of IgG. But when we kill the plasma cells with the chemo, down goes the IgG, right down. He's an excellent response. He's treated for about a year, gets no treatment after that, but we see him regularly in the clinic, and all of a sudden, whoop, up goes the IgG in 2008 or something like that. And he gets then treated with second-line treatment. He gets actually thalidomide to start with, and then lenalidomide, and then gets another excellent remission. And in 2016, he's still in a pretty good going remission. So a patient who's done very well. But the importance of this for us is that we measure this each time you guys come. And we can tell for most of the course of multiple myeloma whether it's getting better or worse by the protein levels. They're a very important measurement for us in assessing what's going on. There's a caveat. As you get later on in the course of multiple myeloma, sometimes it loses the ability to produce protein, and then you can have trouble without necessarily seeing it in the protein levels. But that's a minor thing for right now, at least. So does the protein do any damage? Well, back in London, UK, in the 19th century, they had a patient who, in retrospect, had multiple myeloma. They didn't know what it was at the time. His name was Thomas McBean, and Thomas McBean's urine had a whole bunch of protein in it, and they couldn't really understand it. And they sent it off to this guy called Henry Bence-Jones, who boiled the urine and showed that you got a precipitate in the urine as it got hotter and hotter, and then when it got really hot, it redissolved. And because of that, this protein got called Bence-Jones protein, and still often is referred to as Bence-Jones protein. Some of you may have heard the term. We now know that Bence-Jones protein is free immunoglobulin light chain. Free immunoglobulin light chain gets in your urine. The reason it does that is because it's a whole lot smaller than the antibody molecule. So your kidney consists of a whole bunch of little sieves with holes in them, and molecules that are bigger than the holes don't get into the urine. Molecules that are smaller than the holes get in the urine. So your whole antibody molecule with 2 heavy chains and 2 light chains is big, and it can't go through the hole. So your kidney doesn't care about the whole IgG or the whole immunoglobulin A, but the light chain is small enough that it can get through the holes. So you start to, if you have light chain myeloma, or if you have myeloma that's producing an excessive light chain, even if it's G myeloma or A myeloma, you begin to get light chain in your urine. Sometimes that does absolutely nothing. There are some patients with buckets of light chain in the urine and nothing happens. But in some patients, the light chains will precipitate in the tubules and block them. And that is known as myeloma kidney. So what you're looking at here is actually a slide of a section of kidney showing myeloma kidney. And you're not familiar with these, I know. But when you look at a section of kidney, what you usually see is a whole bunch of little tubes, which you can see here. You can imagine these circular things are all tubes or tubules, as they're little. And you can see, though, in this one, for example, there's kind of a pinky substance, and it's in this one as well, and in that one, and in that one. And that is, they call that a cast. It's made of light chain. It's your immunoglobulin light chain that's precipitated together, and it's just blocked your kidney tubule. And because of that, then the kidney fails. So kidney failure is an important manifestation of multiple myeloma. like everything else, it doesn't happen to everybody. Some people get no kidney failure at all, and for some people they present with kidney failure, wind up on dialysis and have nothing else wrong with them. So again, there's a very wide variation in what actually happens to patients. You get a selection of these manifestations. So what we teach medical students to take home with them is that multiple myeloma equals a monoclonal protein with some clinical consequence, some damage occurring as a result of the monoclonal protein or the tumor. So we say M protein plus CRAB. It's got nothing to do with the crabs I showed in the plasma cells, it's just a happenstance. So the damage then in myeloma can be encapsulated by this acronym CRAB. C is for calcium, R is for renal, which is kidney, so high calcium, kidney failure. A is for anemia as a result of the involvement of the bone marrow, and B is for bone trouble. Now, not everybody who has a monoclonal protein has multiple myeloma. It turns out in the population, if you go looking for monoclonal proteins, you will find them, about 5% of people over the age of 60. So, and they're usually small, and they're usually not doing anything. And that condition is called MGUS. So, it's an awful name. So M for monoclonal protein, so we've dealt with that. G for gammopathy, and if you remember those monoclonal proteins I said ran in the gamma region on that SPEP, that's why it's called a gammopathy. Gammopathy just means you've got trouble in the gamma region. So it's monoclonal gammopathy, and it's of uncertain significance because we have no idea what's going to happen. Mostly, nothing happens. Mostly these proteins remain small and you just keep them, and it doesn't cause damage. A proportion of them, and it's about 1% per year, will go on to get multiple myeloma. So the commonest cause of a monoclonal protein in the population is actually this MGUS thing. And a small number of the patients will go on to get multiple myeloma. It is believed, though, that patients who actually present with myeloma probably had this MGUS going on maybe for 10, 15 or more years prior to them developing myeloma. And lastly, we have a third category, which I don't like very much, smoldering myeloma. So this is the presence of a monoclonal protein in greater amounts than you can allow for the MGUS category, and it is or that you have too many plasma cells in your bone marrow. If you've got more than 10%, you can't get called MGUS. So it's kind of an artificial category, but we treat it like MGUS. We just watch and wait. And many patients with smoldering myeloma will smolder for 20 years or more sometimes. So anyway, just so you have an M protein and no CRAB, but you've got really too much M protein or too many plasma cells to be called MGUS, and that's smoldering myeloma. So that's all I'm going to say about multiple myeloma. I'm going to move on a little bit to stem cell transplants, and I'll speak for 5 or 10 minutes about that. This is the 70s in the UK. This is a guy called Tim McElwain, larger than life in many ways, physically as well as mentally. And the other guy on this is a guy called Ray Poles, who's at St Bartholomew's Hospital in the UK. They were advocates of dose. So back in the 70s, there was a feeling that if you could escalate the dose of chemo, you would be able to cure cancers. And the problem was, of course, that if you do escalate the dose, you get toxicities that can themselves be life-threatening. But they reasoned that if somehow you could get round the toxicities of the chemotherapy and give high doses of it, then you might be able to either cure the cancer or at least improve the outlook. And it was a very widely held view, and it was researched quite a lot, and it mostly failed. The most spectacular failure was breast cancer. Dose escalation was used for breast cancer in a big study, and it bombed. and was abandoned. But for multiple myeloma and lymphoma, it actually turns out to be a useful thing to do. And it benefits patients and it prolongs life. And for multiple myeloma, it's not curative. There was a hope originally that it would be, but it does extend life. And for some lymphoma patients, it is actually curative. So what you need then is a cancer that will be responsive to higher doses of chemotherapy, as opposed to the regular doses. And that turns out to be true for myeloma and lymphoma. You also need a drug whose toxicity is limited to the blood toxicity, and that the next toxicity occurs much higher than that. So for melphalan, for example, its principal adverse effect is on your bone marrow. And if you give enough melphalan, the reason people don't survive is that their blood dies and doesn't recover. The next level of toxicity, as some of you I'm sure know, is on your mouth and your bowel, and you get trouble with when you have your transplant, you get trouble with sore mouth and sore bowels and stuff. And so that's the next limiting toxicity. But if you can get over the blood toxicity, then you can actually escalate the dose of melphalan in a very meaningful way. So what you do, of course, as you know, is you take from the blood stem cells. So all blood cells are grown from what's called a stem cell. And that stem cell can make red blood, it can make white blood cells, and it can make platelets, and it make your immune cells, the whole 9 yards. And it turns out that you can get these things relatively easily from the blood. So the principle then behind stem cell transplant for multiple myeloma is basically to escalate the dose to get a better response with the myeloma than you would otherwise have done, and then to rescue the patient by giving the stem cells back. So you give your high dose of melphalan, you harvest your stem cells first, you put them in the freezer, give the high dose of melphalan, let that wash out for 48 hours, and then you give the stem cells back. And it's a very simple thing to do. You just give them intravenously, and the stem cells are programmed. They're clever, they're addressed, they know where they're going to go, and they go and live back in the bone marrow, and they begin to produce blood, and it takes them about 2 weeks. So you have a couple of weeks of very low blood, and it's an unpleasant thing to go through, I'm aware of that. But at the end of that, your blood's growing again, and your myeloma's in better shape, and you actually can remain in remission after that for reasonable periods of time, sometimes very long periods. This, you'll see some of these people sitting around here, they're at the back mostly. This used to be the transplant team. I don't direct the transplant unit anymore. It's been taken over by a nice lady called Sita Bella, and I don't have a photo of her. But this is the stem cell team, and they're all actually here today. All of us are here, in fact. Yeah, so, and we're standing on the stem cell unit in KGH. So we have a nice new director. We also have nice new machines. This is the old machine, and what it shows is that there's a pipe here that's going up to the patient's neck, and the blood is coming out of a large catheter into a big vein there. Blood comes out of there, goes in the machine. The machine spins the blood, and the red cells wind up on the outside when it's spinning. It spins in a kind of a belt, and on the inside is what's called the plasma, and the space between the plasma and the red cells. There's a concentrated layer of what they call mononuclear cells, and those mononuclear cells are what we harvest. And they contain the stem cell fraction. It's not pure stem cells, but it's enriched for stem cells. And then those are pumped up into one of these bags up here. One of those is the stem cells. I'm not sure which one. And at the end, we run this machine for several hours, and then we send the stem cells off to be counted. And if we've got enough, then we stop. And so we know how many we need. We just keep going until we get enough. So that's the stem cell harvest procedure. They go away to Ottawa, they get mixed with a chemical called DMSO to stop them being damaged when they freeze. So they get frozen down, and then they come back to us in these packs, and this is a pack of frozen stem cells. And this thing is a water bath at 37 degrees, and what she's going to do is dunk it. So you just dunk the stem cells in the water bath, and they thaw. Mostly the bag doesn't break, but it did do once, which is a bit of a problem. But don't worry, we double bag them, so that we have a protocol for getting them back. If the first bag breaks, we got them in the second bag. Okay, and that's Kingston's first autologous stem cell transplant, and you can tell it's a long time ago because I got more hair. And I wish I'd been able to keep it. So I'm going to stop there, and I guess we take questions. If anybody has questions, you're welcome to ask them.
Thank you, Dr. Matthews, for such a comprehensive overview. We've got plenty of time for questions, about 20 minutes or so. So this is a great opportunity to ask questions of an expert, anything that he's gone over or any other questions that you're wondering about. So Shanika's at the back with a microphone, so you can raise your hand and we'll go from there. First one's over here.
Dr. Matthews, quick question about the results of the results of the stem cell transplant. Some people get a complete response, other people get partial responses. Can you comment on maybe why that happens and what is being done to try and get more patients to get a complete response?
So responses in multiple myeloma are categorized according to how good they are. So we have partial remission, which is down to 50%. We'd use the monoclonal protein. So if you get to 50% on your monoclonal protein, you have a partial remission. If you get to 90% reduction, it's called a very good partial. If you get to 0 on your monoclonal protein, it's called a complete remission. And if you get to 0 monoclonal protein and you have no plasma cells in your bone marrow, that's called a stringent complete remission. Why that happens is probably not to do with the drugs we use, but more to do with the way that myeloma is constructed. So myeloma in every individual patient is probably a little different from everybody else. It's not like everybody with myeloma has the same disease. They all have cancers of plasma cells, but the genetic underpinnings of that cancer are different in everybody. And the responsiveness then is built in, I think, to the cancer. In general, what you do, though, and what has been done, is to try and get a preparatory regimen for the stem cell transplant that will give you the best possible response prior to the transplant, in the hope that by doing that, when you've done the transplant and gotten the bigger kick from the melphalan, you'll get down to a complete remission. Now, it doesn't happen to everybody, and we don't understand yet what the genetic changes are that lead to you not being responsive. We do know, though, that if we do what's called cytogenetic testing or FISH testing on the myeloma, we can find certain changes that predict that somebody's going to get a better remission rather than somebody's with a different change. So there are things that we can use to kind of predict it, but we aren't able to manipulate those properly yet. But less in this institution, but certainly in some of the bigger institutions like the Mayo and in Toronto, they're beginning to stratify their approach to myeloma patients according to risk group and trying to tailor the chemotherapy to suit the risk group, so to speak. So if you have high-risk myeloma, maybe you give this kind of combination of chemo, and if you have low-risk myeloma, maybe this combination of chemo would be better. Problem is we don't know yet what the combination should be. So it hasn't reached what you might call prime time or general use yet. But people are always working on trying to improve the depth of response. And just one caveat, if you like. The thing about multiple myeloma is that nowadays, and the treatments have got an awful lot better in the last 10 years, we have lots and lots of different drugs, so we can often get a response multiple different times. And maybe it doesn't matter so much about the depth of the response and maybe it matters more about the duration of the response. So maybe getting a stringent complete remission isn't necessarily as important as it might be, if you see what I mean. Yeah, because if you can achieve a partial remission for 15 years, and you're healthy and you're okay, and you've converted myeloma into a chronic disease, let's say, by using drugs, we do with other neoplasms, maybe that's going to be as good. So chasing stringent complete remissions is often what is done in clinical studies and clinical trials, but whether it's the right thing to do or not in multiple myeloma, I don't know, and I don't think anybody does. It's an area of controversy. Sorry, it's a very long answer to a good question.
Any other questions?
I'd just like to thank the KGH crew for helping everybody here that does have myeloma, multiple myeloma. But my question to you would be, why is it that some patients can't get stem cell transplants?
Well, it's not. There's nobody that can't. I mean, technically, we could transplant anybody we like. So, as always with a medical treatment, you have to figure out whether the benefits are worth the risks. And there are some considerable risks in stem cell transplants. You have to have a very big dose of chemotherapy. You're going to run your white cell count down virtually to zero, and you're going to be without protection against significant infections for a couple of weeks, and you might die of it. So if you have some disease, let's say you have bad lung disease before you have your transplant, you'd say, okay, this is going to be too dangerous. And it's also, the older you get, the more dangerous it gets. So it used to be that we would cut off stem cell transplants at about 65, believing them to be too dangerous. That boundary has been pushed upwards, I think everywhere, and we're transplanting here and patients over 70 now sometimes. But there comes a point where it becomes more risky than beneficial, and I think you just have to, making that judgment's a very difficult thing to do. Yes, you're weighing up things, and a lot of it depends on what patients want to. If they want to take the risk, and then, you know, fine. If they don't, some people don't want to take the risk. So it's a benefit-risk equation that's hard to make. Yeah.
Hi, my first comment is that was a really great presentation. Thank you.
Thank you.
My question has more or less to do with my immune system. I had a transplant in 2012. I have no discernible end spike right now, and so I'm very happy. I'm feeling good. My problem is I also have COPD. So the health of my immune system is important with respect to other problems that I have. And my understanding is after a stem cell transplant, your immune system is compromised and will be for a long time. My question is there anything you can do about that to try to improve the health of your immune system?
Okay, it's another good question. Plasma cells are the end result of what are called B cells. So it's all part of the B cell system. And B cells produce antibody. It's their job. Anybody, and there are lots of different kinds of B cell cancers, but the general truth is when you get a B cell cancer, your regular B cells give up the ghost and don't function properly anymore, and they never recover it, even if you get your cancer in remission. So that goes for indolent lymphomas, diffuse large B-cell lymphoma, and it also applies to multiple myeloma. So the immune deficit is permanent, and it's not so much due to the stem cell transplant. The stem cell transplant gives you temporary immunodeficiency because we knock your immune system right down, but the permanent lack of ability to produce antibody is due to the fact that you had a cancer or a neoplasm of your B cells in the first place. So anybody who's had multiple myeloma or lymphoma is permanently at risk of getting repeated infections. Now, not everybody gets the trouble. Virtually everybody will have low levels of normal antibody, but most people don't seem to get into trouble, but some do. And the only thing we can, well, there are a couple of things. If you ever get shingles, you need to get the anti-shingles antibiotic, regardless of what they tell you in Emerge. you need to get that. So shingles is a permanent problem. But if you begin to get recurrent episodes of pneumonia, which some people do, then we can replace the antibody with normal antibody. So it's called intravenous immunoglobulin, so intravenous antibody. It's normal antibody prepared from normal people. You can give it once a month, and it helps people keep out of trouble. But there's nothing we can do to restore your innate ability to produce antibody. It's gone, and it won't come back.
Thank you very much, Dr. Matthews. That was a wonderful overview. I just have a question about what you said in terms of shingles, because I had the shingles vaccination long before I got multiple myeloma. Then I had, through you, the stem cell transplant, and about 6 months later I got a full-blown shingles outbreak.
Yeah.
Should I be getting a shingles shot again, or is...
Okay, another bunch of good questions. So when we look back at our data on the transplant unit, one of the things we discovered that lots of people were getting shingles, and we were giving the acyclovir for a fairly limited period of time. We've now extended that period of time to much longer to get over the shingles problem for people who've been transplanted. And arguably, you might want to take the shingles pill permanently. I can beginning to think that, although I don't have any really good evidence for it, but you take your 800 milligrams of acyclovir or Zovirax once a day, and it keeps people free from it. The shingles shot, it's an attenuated virus, and the advice is still not to get it if your immune system isn't great, just in case you can't handle even that attenuated virus. Plus, it's unlikely you'd get a really good immune response anyway because your immune system isn't working. So if you want to protect yourself against future shingles, my own view is that you'd be best off taking a single 800 milligrams of acyclovir once a day. Shingles isn't very nice if you get it, I know that.
There's a question from one of our viewers on the webcast. Dr. Matthews, the patient writes, I'm a 72-year-old MGUS with 3 grams per liter, detected June 2015. Does recently found high free kappa value, 26.7 milligrams per liter, constitute as active multiple myeloma? Other parameters are normal excepting vitamin D.
So the short answer to that is no. The patient is talking about a test called free light chain testing. And it's a very, very sensitive way of looking for free light chains in the blood. And you measure both kappa and lambda, and everybody, turns out, has free light chain in the blood. Normal people have free light chain in the blood. And your free light chain test is sensitive enough to detect that. When you start to look at patients with MGUS and look at their free light chain values, quite often you find that they're elevated. The patient here refers to a level of 26 as high, but in fact, in the myeloma world, that's actually a very, very tiny increase. We see light chain levels in the hundreds of thousands sometimes in patients with good-going myeloma. So a level of 26 is, first of all, it's a very low level, and the fact that you have a little excess of free light chain in MGUS does not mean you constitute multiple myeloma. You need to demonstrate that the monoclonal protein is there and you have CRAB. And if you don't, then you don't have multiple myeloma. I wouldn't be at all worried about that free light chain level. I think that level of monoclonal protein, 3 grams per liter, is very small. The patient who asked about this likely has many years to go before they get any trouble, and probably won't at all. And that free light chain level doesn't influence the outlook at all. So the outlook is good, basically, and remains good.
So we talked about the cause of multiple myeloma in the plasma cells themselves. What do we know about what triggers that, or the problems associated with the genetic makeup of the plasma cells themselves? Is it environmental? Is it genetic? What do we know about that?
Very little is the answer, unfortunately. We can see what goes wrong. You can detect these changes in the genetic code, but what you don't know is why they happened. And your only route into that is to try and find some correlation with environmental factors like occupation, like radiation, like chemicals, maybe looking at families to see if there's a familial relationship. And there are some suggestions that it might be environmental, but nobody really knows what it is, to be quite honest. There are certain families, though, that do have more than one member with multiple myeloma, and so you begin to think that those families have something that makes them predisposed towards it, but whether they were uniquely exposed to things as children or whether they inherited some change in their immunoglobulin genes, nobody knows. So that's an excellent question. If you could answer that question, you would be a very famous man and get a Nobel Prize, I think. It's generally true for most neoplasms. We can see what goes wrong, but we don't know why. To some extent, it may just be bad luck, because your genes have to replicate themselves so many times, and if they do it wrong one time in a critical area, it could wind up as being multiple myeloma. And it could perhaps help me, but I think radiation's been linked, and I think agricultural occupations have been linked, but they're not very strong linkages at all. Is that? No. Okay.
I wonder, Dr. Masters, if you have anything to say about an article that was in the Toronto Star this week with regards to Princess Margaret and Hamilton, I believe, closing their doors to allogenic transplants.
You want me to be a politician, I think, now.
I didn't know if that,
affected us?
Yes.
So it doesn't affect our autologous transplant program, no. We don't do allogeneic transplants in Kingston, although we're aiming to start doing them perhaps over the next year or so, partly in response to this undersupply of allogeneic transplant in Ontario. It's become clear over the last 12 months or so, and maybe a bit longer, that we don't have sufficient capacity to transplant all the people that need to be transplanted for allogeneic transplants. Autologous transplants, we're okay, and we can do everything we need to do in Kingston. But for allogeneic transplants, which for those of you who don't know is transplant from a different person, and it's not used for multiple myeloma. It used to be, and it might be in the future, but right now it's too risky. But there's an undersupply. And Cancer Care Ontario now is the owner of allogeneic transplant provision, so that they are landed with the responsibility of making sure there's sufficient capacity, and they're working very hard to try and improve capacity. But it's hit hardest on Princess Margaret and Hamilton. Ottawa is still able to expand and take more patients, and we here have shifted the bulk of our allogeneic transplant referrals to Ottawa instead of PMH. And that I think will be a productive relationship, because they will help us set up our own program, and I'm hopeful that we'll have a program here maybe in the next 12 months. It's a big job to get done, but I'm hoping that will happen. Something like, well, I don't know, I didn't actually read the article, I heard about it. But what Ontario is doing is referring people to the US for transplants, out-of-country referrals. I think there have been something like 200 people approved for out-of-country transplants. So they're doing their best to cope with the demand. There's some development work going on in Toronto and at Hamilton and London and Ottawa and here, and I think we will eventually solve the problem. But right now we have a very immediate problem with a demand that exceeds supply.
Dr. Matthews, the question I have is regarding the second transplant. Perhaps you can maybe enlighten us on what's the current thinking and what decision points would be made to decide on a second transplant versus just using some of the novel drugs that are available? Thank you.
Okay. So there's two circumstances that a second transplant is used. One is a procedure known as tandem transplant, so where you do two transplants back to back up front, and that's an attempt to get a deeper remission in the hope that that will translate into longer survival. And there is some evidence that that might be the case. It is, though, attended by a lot more morbidity and some increase in mortality, so not everybody's doing it, and we certainly don't do it as standard. The second use of a second transplant is if you've had a remission after your first transplant and you need another treatment. Do you go for a second transplant, or do you use a quote-unquote novel agent? And there isn't a lot to guide you on what you should do. So in favor of doing a second transplant is that if it works for you, then you've still got your novel agents later. So you're not ever using them. You can use your transplant and get what you can out of that, and then you can use your novel agents later. Against transplant is that if you relapse fairly soon after your original transplant, you're not likely to get much bang for your buck. So in practical terms, what we look at is the age of the patient, their general health, whether they're strong enough to go through a second transplant, and how long they got after the first transplant. So if you're relatively healthy and you've got a decent amount of time, then we can think about doing a second transplant. And we do, in fact, routinely harvest, if we can, enough stem cells for 2 transplants with that in mind. The number of second transplants we have done is actually fairly small, but we've done some, and sometimes with good effect. So it's the length of time after the first transplant that you got, and what your, how you are clinically, your general health and strength.
Thanks again, Dr. Matthews. That's a great kickstart to the morning, and I think sets a really great stage for our discussion later on. So I think we're going to switch gears here a little bit, and I'm really excited to invite our next speaker up to the podium. So our next speaker is named Leslie Weatherby. Leslie is a 69-year-old semi-retired registered nurse. She's a mother of 4 and a grandmother of 7. Leslie was diagnosed with multiple myeloma in August 2010, and in March of 2011, she had a stem cell transplant here at Kingston General Hospital. Leslie's been involved with Myeloma Canada since 2013, and in 2014, she actually started a myeloma support group for patients living in her area and her hometown of Cobourg, Ontario. So Leslie is happy to assist Myeloma Canada with advocacy for all who are affected by the disease, and today she's going to share her story with us. So I'm going to welcome her now to the podium. Sorry, I'm just going to put this up here.
There you go, great. I'd like to thank Dr. Matthews as well for, is the speaker all right? Okay, for that the talk. I've heard, 8 or 10 descriptions of what multiple myeloma actually is in the last 6 years, and that was the best one. Yes, the very best, to our level of understanding, and clarified even still some things for me, so tremendous. Good morning to everybody, and a particular thank you to Aldo and Jessica for inviting me here today to share my story. I'm really honored to be doing that. And something that I would like to know before I get started is how many people here are actual patients? Just a show of hands? Great. And then caregivers? Who's here as a caregiver? Yeah. Tremendous. Okay, that's a tremendous turnout today. As the bio states, I was diagnosed with multiple myeloma in August of 2010. And during the 6 years, I have learned, and speaking with patients, that all of us have a very different story to tell about our pre-diagnosis and how we learned eventually that we had multiple myeloma. So I'm going to share my story just very briefly about my pre-diagnosis symptoms. In Thanksgiving of 2009, I hurt my back lifting a 20-pound turkey out of the oven at Thanksgiving. And a couple of days later, it was still bothering me fairly significantly, and I went to my family doctor, and he said, "Oh yes, you've got, turkey back," as what he called it. And he gave me some anti-inflammatories and some pain medication, and it got better in a few weeks. And then in early 2010, I developed a fairly bad abscessed tooth, and a few weeks later, an infected hangnail, both of which needed antibiotics to cure. That was a bit odd for me that I very seldom had to take antibiotics, but that was a beginning sign something was going on with my immune system. In April of that same year, I developed my usual upper respiratory infection. I always tend to get a cold in April. But this year, that year of 2010, the cold progressed into bronchitis, which stayed with me for many weeks. So another sign, things just weren't 100% with my immune system. Then in July, I went back to my family doctor again with some lower back pain because I'd been doing some gardening. And this time he ordered a CT scan just to see why I was continuing to see him with this back pain. And a few days, he ordered a CT scan for that. And a few days later, I got a call from his office to ask me to come in to see him to discuss some lytic lesions that had been observed on my CT scan. Well, at this point, I was a 42-year veteran of nursing, and I had not heard of lytic lesions. I didn't know what they were. So like a fool, I turned to Dr. Google, and you should never speak to Dr. Google when you need compassion, because he just upfront diagnosed lytic lesions as destructive areas of bone caused by disease, either cancer or very frequently seen in myeloma. So that started my, my journey of further tests. And after more blood tests and X-rays and scans, urine samples, and finally a bone marrow biopsy, in August of that year, I was diagnosed with the multiple myeloma. And then in September, I was bedridden. It was very interesting to watch your slides of the compression fractures, Dr. Matthews, because in September I was bedridden because I developed 2 compression fractures in my thoracic spine. But fortunately, by the end of September, I was well enough that I could start my chemotherapy. So in October, I started my induction chemotherapy, which was Cybor-D at the time, which is cyclophosphamide, bortezomib or Velcade, and dexamethasone. And I had 4 treatments of that for 4 months and responded very well. I have a light chain myeloma, and my light chains on diagnosis were 6,300, and after 4 months of treatments, they were down to 107. So everybody was very pleased with that. Then in February of 2011, I was referred to Kingston General Hospital and had the pleasure of meeting Nancy, and Rosemarie was her co-companion there at the time with Dr. Matthews of the stem cell unit here. And after the month of February, being prepared with all the things that you're prepared with for the stem cell transplant, I finally had my transplant on March the 16th, which happened to be my 64th birthday, and started my road sort of to recovery after that. Now, one humorous thing that my family still talks about, I had a couple of my daughters were with me the day of the transplant, and they have since developed a horrible dislike for creamed corn. Now, does anybody here not understand that? Well, I see somebody saying, "Well, it's." Yeah. Well, I was prepared and told that I would smell like a can of creamed corn during the transplant, and I think, Nancy, you have to correct me. I understand it's the preservative that, with the stem cells, that emits that odor of the creamed corn. So, definitely, I mean, there's no creamed corn in our household anymore. That's for sure. Now, while I was in hospital after the stem cell transplant, of course, I watched daily the little chart that's on the wall, watching your blood counts go down and then up again. And I was very fortunate and delighted, I must say, that on day 15, the stem cell transplant day being day 0, on day 15 I was allowed discharge from the hospital because my blood levels have reached, an acceptable level to go home. While I was at home, I was monitored by VON community nursing, monitored my general health, my PICC line. We all went home with a PICC line for a bit. And they also withdrew blood on a weekly basis to monitor how my cells were doing. 4 weeks from my discharge, my hemoglobin, and you have to trust an obsessive-compulsive nurse. We're always interested in numbers that have to do with our bodily functions. But I kept track that 4 weeks from my discharge date, my hemoglobin was 121, my platelets were 167, my neutrophils were 3.0, and that was pretty good results. I was very pleased with those. And my creatinine, kidney tests, and electrolytes were normal. Now, while I was at home, my husband was my professional chef for a few months because the hardest thing for me was to regain my taste for food and cooking. But after a couple of months, by late June, I was regaining the 15 to 20 pounds that I had lost, so I was feeling much better for sure. In May, I started monthly visits with Dr. Gordon Swain, local hematologist that now comes weekly to the Coburg Hospital. And I visited him monthly, for monitoring and to monitor my blood cells, of course. Now, I had a very good partial response to the stem cell transplant, and as I mentioned, I have the light chain variety, but I also showed a high-risk cytogenics, which is a chromosomal abnormality of 17p, which makes myeloma possibly harder to treat and a little more aggressive. So we discussed that issue of 17p for a bit, and Dr. Swain agreed that maybe I should go to Princess Margaret and have consult with the myeloma team there. And in February of 2012, I visited Dr. Christine Chen, who works with Dr. Reese and some of the other myeloma specialists at Princess Margaret. And she suggested that I start on a maintenance program of Revlimid, 10 milligrams, which I did. I started that in February of 2012 and continue with that medication routine at the moment. I'm very, very fortunate to have manageable side effects. Fatigue, I think, is the one that irritates me the most, but I mean, that's pretty little to to know that it's doing what it's doing for me. And I do have constipation and bloating and some neuropathy, which I'm sometimes being told that the Revlimid is not cause for the neuropathy, but I find that after 4 years of taking it, that I do have increased peripheral neuropathy in my feet. I'm very encouraged with the advance of drugs that are being researched and developed now for our disease, my disease. I know that when I'm finished, when Revlimid or lenalidomide becomes ineffective for me, that his cousin, which is pomalidomide or Pomalyst, is waiting there to pick up the baton, so to speak. And there are many new emerging combinations of drugs, 2 and 3 drugs at a time. And as Aldo stated, this year is going to be a tremendous year with the approval of 4 or 5, I think you said, didn't you, Aldo? 5 medications. So if we're going to belong to the myeloma family, certainly we're very fortunate to belong to the family at this stage. And I do, and we all do, look forward to the day, I think, when myeloma can be classified as a chronic illness. So much for the physical aspect of my journey. I am a believer that a journey with a life-altering illness has an emotional and a spiritual side that can work negatively and positively with the physical side. I thank my mother and my grandmother for passing on to me their belief in a power that's higher than my own, and that has been a great comfort to me in the course of this, with prayer and taking life day at a time. That was very difficult for me because I was a person who was always looking ahead. I'm going to do this next month or next year, and it took me a while to realize that a day-to-day is certainly the way to go, and it's been a benefit for me. Emotionally, it was a little maybe more difficult because my husband and my family will attest that I'm a person who hides my emotions. And during the myeloma journey, I was surrounded with all kinds of compassion and empathy and love from family and the medical people, but I still felt like I was in a crowd of strangers, looking for somebody that I recognized and that I could talk to and had gone the same path that I had gone. And myeloma, I knew, was a rare cancer, and it was 2 or 3 years before I found another rarity like myself, and that was in attending the Toronto and District Myeloma Support Group that's held in North York. That's a very large group, 50-plus people at that support group, and my husband and I attended that in 2013, yes, in the spring of 2013. And that was a huge support for me, listening to other patients who had talked of their journey with myeloma for 5 years, 7 years, sometimes 10 years. Chatting with people who use the myeloma language. I mean, we talk about, DEX highs and induction therapies and Revlimid and all these different words that our own families look at us like, we have horns or something. But when you're actually talking to the other people dealing with the same condition, those words are very meaningful because that they understand what you mean. After attending that support group a couple of times, I was then committed to starting one myself in our small town of Cobourg. As at the time, I learned that there were no support groups from North York, Toronto, east until you got to Montreal, so a large gap. And I would really like at some point to advocate for the support groups in the Kingston area. I think there's a huge population here that could benefit from that, particularly when it's a center for transplants. Now, with the help of some of the group leaders from Toronto, and the fact that I had some experience with facilitating support groups through breast cancer, because I had breast cancer in 1985, and so in those 25, 30 years I had a fair bit of dealing with breast cancer support groups. So I felt comfortable at starting a group, and with the help of the nurse manager at our local oncology department in our hospital, I was able to advertise to the 10 or 12 patients visiting Dr. Swain in that clinic that I wanted to start a social and support group. So in April of 2014, we had our first meeting, and we had 8 people, patients, and their spouses or caregivers. And at the moment, we have somewhere between 10 and 14. Not a large group, but it's very informal. We have a chat about where we are with our journey and our illness, share information, laugh a fair bit, and we all do this all over, tea, coffee, and cookies. One of our newest members to our support group has allowed me to quote her description of how the support group has helped her. Now, she has said that the common bond provides emotional support. It makes us feel less isolated, anxious, and scared. The educational, information, and the advocacy opportunities allow one to gain some control over this disease and your new normal. Her husband also stated that it's a space for caregivers to air issues and problems they face, and they see that they're not alone as well, and the difficulty that they have dealing with day-to-day activities. Now, there are 23 support groups, approximately, give or take, a couple across Canada. And as I've already stated, I really hope in the next fairly close future to see a couple more just in our area, Peterborough, Kingston particularly. We are ever thankful to Aldo for his vision and dedication in starting Myeloma Canada some 11 years ago, because without Myeloma Canada's support, these support groups we'd struggle. Every year, Myeloma Canada offers a national conference for all support group leaders to meet at in a different city every year. And this year it's going to be in Edmonton, isn't it, Aldo? Yes. And that's strictly a meeting of the support group leaders to share ideas, to really promote advocacy. Advocacy is a hugely important thing, and certainly in our Ontario branch. And without the support from Myeloma Canada, we wouldn't be here today for sure. It's a tremendous community, and thanks to Aldo and everybody else. And it's a community that I'm really proud to be part of. So thank you for that, my little story.
Thank you, Leslie. We have some time for questions. If anyone has questions or comments, or we have about 10 minutes before the break starts, so I'll open up the floor for any questions. The mic?
Hello? Yeah. So thank you for that talk. That was very, very, very nice. I was just wondering, when you're thinking about setting up community support groups, What would be helpful to get from the treating institutions? Is there something that we could do to be helpful to set up support groups? Because I've seen for a long time that Kingston doesn't really have a support network, and it would be nice to have. So is there anything useful that we could do in that respect?
Well, as I mentioned, Coburg's own oncology department was very helpful to me. The nurse manager, for reasons of confidentiality, of course, she just couldn't give me the names of all the people that were in the clinic, that had multiple myeloma. But she organized a small info session in our local hospital, inviting the patients and their families to this info session. And she had a couple of speakers, and she had a tremendous turnout. And the two of us kind of collaborated with this. And so she said, well, we'll have this info session, and then I could come and introduce myself and make known that I would like to start a support group, and what a support group entails. And that particular day, I took names of people that were at the info session that, were interested in the support group. And a few weeks later, I contacted them, and we sort of started from there. As I said, it was a small group. I had maybe 8 or 10 people at the first group, and I held it in my home at that time because I knew it would be small. It has grown, and now we've moved on to a sort of a more neutral place. But this session here today would be tremendous way to start, and whether, I would certainly be willing to come down and help out with the, initial beginnings of a group, but if that's something that's an option in the future.
I think if anyone is interested who's in this area, if you can maybe let Shanika or myself or anyone else that's helped to organize this event, and then we can get an idea of the interest, and we can also get your contact information. So I think that's sort of a grassroots way that we could try and get it started. But I think opportunities like this are great when everyone's together in a room, and
It's good to have a little bit of facilitator training. I think if that does, and that's something maybe Myeloma Canada is maybe going to think about. But I
think we have a question over here.
I guess I'm going to direct this to Aldo, because I've always been interested in doing something with it, but I have a lot of things going on in my life that require attention as well. So I'm kind of wondering if you could do this along with another person that would maybe be interested in doing it as well, because I wouldn't want to commit myself and then have to back out. And I don't think I would have to, because my condition is stable, and as far as my myeloma goes, I'm okay. But there are other things in my life that require a lot of time. So would that be a possibility? Or, I always talk to anybody I meet at the cancer clinic that has myeloma, and especially if they've just been diagnosed or they've been doing a little bit, it just helps them to hear that I have survived as long as I have, and so it gives them hope, and I would love to be involved in a way. I would go to the group meetings anyway if somebody else took it on, but if it would be possible for 2 people to do it together, I'll talk to you after. But I just wondered if that is a possibility.
That's the idea, to have
more
2 co-leaders.
Okay, that's good to know.
Start and run the support group, because you're right, you just can't rest on the shoulders of one person.
Well, and then if something happens to you, they're stuck. So they have to get another one. Okay, that's great. Thank you.
I'm still not totally clear on the real purpose of the support group. Is it to just have people talk to other people to know you're not alone, like a warm, cuddly feeling? Or does it get into technical aspects? And for example, the biggest problem I had here in Kingston when I needed dental work after my stem cell transplant and I'm on pamidronate is finding a dentist in Kingston who actually knew what pamidronate was and what osteonecrosis of the jaw was, et cetera. So that to me is what I'm looking for in a support group as much as the warm, cuddly, fuzzy aspects. Like in other words, for example, finding an orthopedic surgeon who realizes that the reason why your bones aren't healing is because you're a myeloma patient, is a big gap that I found. So if I was a part of a support group, I'd want people to say, well, I had an orthopedic surgeon in Ottawa who understood this completely, and he's not going to argue about the fact it's 12 months after you fractured your back and it's still not healed, and he knows what to do about it, as opposed to saying, I'll ignore it. So maybe you can address it. Is it a social club, or is it to exchange technical information, best practices, and medical professionals who actually understand myeloma as it relates to all of the non-myeloma issues that people have to face?
Now, I appreciate that. Every group, support group, has kind of a different focus. The group that I run is small, and at this point, it's a social and a collaborating of ideas. And yes, during our group, somebody might say, I had to have a tooth extracted, and so I found this, a dentist wherever that knew what to do because I'd had myeloma. In other groups, like the Toronto and District Multiple Myeloma Support Group is a large group. I said 50 or more people. Their focus is to have speakers come, and every couple of months they'll have a different speaker, and it might be an orthopedic surgeon, it's a hematologist, all speakers related to dealing with myeloma. So after a support group is developed, then it's up to the group members as to where they want to take this support group. Do you want it to be a fuzzy social and we get together and laugh and have tea, or do you actually want to have some structure and have speakers? It is an individual. Now, as far as having medical questions yourself that you want addressed, if you can't kind of get those questions answered through your own physicians, Myeloma Canada is an excellent resource. And I know personally, and from other people I've talked to, they've spoken to Myeloma Canada with a particular question, and if their answer wasn't immediate, somebody found the answer for them. So, and certainly, I'm the first one to say that support groups are not for everybody. Many people, once they've dealt with the disease and they've had the treatment, they're home free and they don't want to talk about it anymore. And that's fine. We're certainly all individuals, but for those that do like that support, and from my perspective, being in a small community, and because I nursed in that community for so many years, I've had phone calls from people dealing with multiple myeloma. They don't want to come to the support group, but they know there's a leader of a support group, and they would just call me with their own personal question. Sometimes I can help them, and sometimes not. So that helped. Great. Okay.
Thank you. A round of applause, I think, is warranted for Leslie. All right, so at this point in the morning, we're going to take about a 20-minute break. So it's 11:15. So if everyone wants to come back at 5 after, or sorry, is it quarter? Yeah, 11:15. If everyone wants to come back at about 5 after, so about 20 minutes, you can stretch your legs, go to the washroom, get some more coffee or tea, go outside if you want to get some fresh air. So Just another couple just quick housekeeping things. There are evaluations on the tables. If you're able to fill your evaluations out by the end of the session, that's really helpful for us because it gives us an idea of how we did and what you'd recommend for the future. There's also a partner of ours, Dr. Langley. He's the primary lead in our region for the Southeast Regional Cancer Program. So he's a friendly face and has a lot of general information about health promotion and cancer screening. So if you want to go over and say hi to him and see some of the materials that he has during the break, he's available as well. So we'll see you back in about 20 minutes. So I'm going to kickstart the second half of our morning. And right now, what I'm going to do is I'm going to reintroduce Aldo. He's going to join us to speak for a few minutes about Myeloma Canada Research Network and introduce our next speaker, Annette Hay. So just to let you know about Aldo, since being diagnosed with multiple myeloma in 2002, Aldo has directed his attention to building an effective national platform to address the needs of the Canadian myeloma community. Founded in 2005, Myeloma Canada is the only national nonprofit organization uniquely focused on the needs of the Canadian myeloma community. As a patient-driven grassroots organization, Myeloma Canada's mission is to provide educational resources to patients and caregivers, raise awareness of the disease, advocate for improved access to new therapies, and accelerate patient-focused myeloma research. And that's exactly what we're going to talk about in the next hour or so. So I'd like to greet Aldo.
Thank you, and welcome back from coffee break to both all of you here and to those of you watching on our webcast. So what I'm going to do in the next few minutes is talk a bit about what we've been working on more or less behind the scenes for the last number of years in building what we have come to call the Myeloma Canada Research Network, or by its acronym MCRN. Our mission, this has evolved over the past several years. We've added to it. We now have three main objectives for the MCRN. The number one is to conduct innovative phase 2 clinical trials and translational research in a collaborative manner to improve patient outcomes in myeloma. Number two is to publish evidence-based and peer-reviewed consensus statements on both the diagnosis and treatment of myeloma. And the third one, which was just added last year, a very important point, is to develop a nationwide myeloma patient database, which perhaps you're surprised it does not exist right now, and you'll see the reasons for wanting us to do this moving forward. I always like to show this particular picture that was taken back in 2009, which basically show the early beginnings of what evolved into the Myeloma Canada Research Network. It was a somewhat informal meeting that took place at a very important annual meeting called ASH, or the American Society of Hematology. I believe this year, that particular year, took place in Orlando. So I thought, let's get some of our doctors together, at least to start the conversation going, begin the collaboration. And I brought a couple of heavyweights in to help us. Dr. Bob Kyle, who some of you may have heard of or know from the Mayo Clinic, who's on the far left, as well as Dr. Brian Dury, who's the co-founder and chair of the International Myeloma Foundation. So using them as draws, I got several of our top doctors from across Canada to attend, including Dr. Rees from Princess Margaret, Dr. White from Halifax, Dr. Song from Vancouver, Dr. Roy from Montreal, Dr. Belch from Edmonton, Dr. Shustik from Montreal, and Dr. Linda Pilarski from Edmonton. So basically that was where the seeds for the Myeloma Canada Research Network were sown. Today, the network stretches from coast to coast. In fact, as of yesterday, there was one more center that expressed interest in joining the network, and that's Kelowna. So now we'll have 21 centers from coast to coast in 9 provinces that are part of the network. And what does that mean? It means that they come to our meetings, they participate on conference calls, they're made aware of upcoming trials, they're encouraged to come up with clinical trial ideas and work together collaboratively, because I think that's the key word. If we want to beat this disease, we've got to work together, bring all our experts working together through, in this particular case, the Myeloma Canada Research Network. And I don't know if you can see clearly, but there are some centers that just do the clinical research, and there are also some other centers that do basic research. For example, Toronto, Calgary, Edmonton, some work done in St. John and in Montreal. And each of these centers, many of these centers has different areas of expertise that coming together as a group we can leverage and really advance research in this country. And speaking of, this is not a complete laundry list, but some of the areas of expertise that I've identified that resides within the network starts with genomics, which many of you have heard is a big area of study, trying to better understand the disease, how people respond, et cetera. That's really being led by the group in Calgary by Dr. Bayless and Dr. Neri. Drug target evaluation, Dr. Suzanne Trudell at Princess Margaret has done a lot of work in this area over the past number of years, and the Calgary group is also doing some work in that area. Minimal residual disease, or MRD, has been a very exciting area of development in myeloma insofar as that it really is a methodology that's used to look at how many myeloma cells are left over after a particular treatment. And if you're MRD 0, it means there are no detectable myeloma cells in remission. It's very interesting to study this area to understand whether that will become a proxy for overall survival. I'm not sure we're there yet, but there's work being done there in Toronto and Montreal. In fact, our very first study, which I'll talk about, 001, utilizes this technology. Unfortunately, as we know, the fortunate thing, we have a lot of new drugs, but unfortunately, in most cases, the drugs eventually stop working. And that is another interesting area of study. Why do the drugs stop working? What is it that changes in the body that creates this resistance to the drug? And there's work being carried out in both Calgary and Toronto. A couple of years ago, Dr. Roger Tiedemann published a paper, a very important paper, postulating on the mechanisms of resistance for bortezomib. Cell therapy, that's an up-and-coming area that's being done out of Montreal. Immunotherapy, high-risk disease, we alluded to that earlier this morning. That's an area that's a bit of a challenge, actually quite a big challenge for the clinician community, and there's not a heck of a lot being done in that area, but the group in Montreal, which I'll talk about, is focusing in on that area. And as I just mentioned, our newest addition is the patient registry, or the national database, which is actually, it's the involvement of 12 centers across Canada, being led by Dr. Chris Venner, who's chairing this initiative out of Edmonton, and being managed operationally by Dr. Masi Khan out of Toronto. One of our important meetings, very important meetings, we get together once a year at the annual scientific roundtable. Remember the earlier picture, there was about 6 or 7 doctors. Actually, there were more people than that at this meeting. This is from a couple of years ago in Montreal. This meeting now has become the go-to myeloma meeting in Canada. There's about 30 to 35 of our doctors that attend, both clinicians and researchers, 8 to 10 pharmaceutical and biotechnology companies. And lastly, we started inviting patients to attend this meeting because as a grassroots organization, I feel it's important that the patient be represented at the table at all meetings that impact their outcome. So this has really grown from that small group back in 2009 to this big annual meeting that takes place every year in Montreal. And next week, the Canadian Cancer Trials Group, based out of here in Kingston, is having their spring meeting, and many of our MCRN doctors will be attending that meeting as well. So just a few of the advantages and benefits of having a national myeloma network is this is really what we talk to pharmaceutical companies about so they can invest money to bring more clinical trials to Canada for our patients. We've had one clinical trial under our belt, 001. It showed rapid accrual. We are cost effective doing this in Canada. We assure quality of clinical trial results. There was a point where some pharma companies decided they could go to other lower cost countries to do clinical trials, but at the end of the day, you get what you pay for, and Canada is known to produce very good quality results. It provides, especially for the small biotechs who don't know the lay of the land, it provides a one-stop access to the whole network. And I'll give you an example of that, how that worked to both our advantage and to the biotech's advantage. Our investigators across Canada are many world-renowned, proven track record. This allows collaboration with international experts. I think the next step in building the network is to work collaboratively with other myeloma groups, either south of the border or across the pond. And I think a very important component is it'll become much more patient-centric. As I mentioned, we invite patients to the scientific roundtable, but we're taking it beyond that to make sure that the patient voice is at the table when clinical trials are being discussed. So why is this beneficial to the patient? First, I think the important thing is with all the new drugs that are coming, there are many more clinical trial possibilities. Historically, many of these trials have been focused on what I call the big 6 centers in Canada, namely Vancouver, Calgary, Edmonton, Toronto, Montreal, and Halifax. Well, patients also live in Sault Ste. Marie and Saskatoon and Windsor and Quebec City and St. John's. So we want to make sure that this network reaches as deep into the community as possible so that more patients will have access to more clinical trials across the country. And myself, coming from a remote Northern Ontario community where I was born, I understand how this is important. Not that we can have a trial in every single community, but the closer we can bring the trials to the patient, the better it is for all involved. And it also increases the possibility of better recruitment. As I mentioned, the patient representation, we are in the process of developing our clinical trial steering committee and our protocol review committee, and there will be patient representation on both of those. The database, the importance of the database is, of course, is to capture data. But this data is real-world evidence data, which going forward will help inform or guide clinical decision-making to improve patient outcomes. And last but not least, it's just this collaborative approach with Canada's world-class research that will promote the collective involvement of patients. One of the ways that this initiative is funded is through our annual Multiple Myeloma March. I'm not here to pitch the march necessarily, but just to explain to you where the funds raised go to help support this initiative. The march itself creates awareness around the disease, it builds community strength, and importantly raises funds to support research and other patient programs, whether they be education or advocacy. This annual event was initiated by a patient or caregiver in 2009. Very small event. Now it's grown to 12 centers across the country, and I've listed them here in 6 or 7 provinces. So what does money raised from this march do? As I said, it does help support educational, awareness programs, advocacy, but it also helps fund research. And I'll cite 3 examples here of where the money goes, because that's what people always ask, where does the money go? First is the establishment of Canada's 2nd academic research chair at the University of Montreal. Second is the Myeloma Canada Research Grant, and thirdly is supporting our MCRN clinical trials. I'll speak a bit about the Myeloma Canada Research Chair. It's based at the Maisonneuve-Rosemont Hospital, which is the biggest transplant center in Quebec. It's led by Dr. Richard LeBlanc, who was a fellow at Dana-Farber, studied under Dr. Ken Anderson. He came back to Montreal a few years ago and helped establish this research chair. I was talking about high-risk disease, where that's an area that poses somewhat of a challenge, and they are looking at the role of allogeneic stem cell transplant. Dr. Matthews did briefly mention that. It's not a standard of care by any means for myeloma, but there's still interest from a clinical trials perspective in looking at this treatment option in treating high-risk myeloma patients. And their trial is well underway. He'll be presenting his results at our scientific roundtable in September. The funds for the research the funds generated by the research chair also helped establish a myeloma tissue bank, which is not unique to Montreal. There are several across the country, but this is yet one more, and researchers from across the country have access to these tissue samples to help their own research. And as I mentioned, this is one of the centers of excellence for minimal residual disease analysis at the University of Montreal. So that's one of the areas where funds raised from the March helped establish this infrastructure to advance myeloma research. Also, we award annually a myeloma research grant. It's peer-reviewed, which means that the researchers send in their proposals, and it's reviewed by a committee of their peers. Myeloma Canada does not go in there and make selections. This is by other fellow researchers that evaluate the proposals. The guiding principle is that the proposals are rated very much more highly if there's a higher probability of that proposal impacting clinical outcomes within the next 3 to 5 years. It's a very difficult criterion to evaluate, but that's kind of the guiding principle. We want to make sure that we're funding research that's going to really help improve patient outcomes in the foreseeable future. A couple of years ago, we joined forces, again here the whole collaboration component with the Cancer Research Society. So we each put in matching funds every year. We award, now the grant is up to $120,000 per year. It started off as $50,000. So over the last 4 years, we've awarded $400,000 in research funding. These are the recipients. Dr. Sabine Mai was our first recipient. She does work out of Winnipeg. She actually won it twice. Dr. Neri out of Calgary won it in 2012. And her work was looking at mechanisms of resistance for the IMiDs, like the lenalidomide family of drugs. Dr. Trudell from Princess Margaret 2013. And last year, Dr. Edmund Young, again out of University of Toronto, won the award. Now to talk to you a bit about the clinical trials that are going on. The first one, they're just numbered according to when they get activated. The first one was activated about 3 years ago, MCRN 001. This is for newly diagnosed patients. It's a transplant trial. And what was different in this trial is that instead of the classic melphalan conditioning, they decreased the dose of melphalan, added another drug called busulfan, basically to see whether that was a more effective conditioning regimen than the standard melphalan. They also incorporated MRD testing at day 100 and also lenalidomide maintenance, which has now become pretty much standard of care, but 3 years ago, lenalidomide maintenance or Revlimid maintenance was not available to patients. So this trial was a way of A, looking at the effectiveness of adding maintenance, and B, providing maintenance to patients. And I'm proud to say we've had 3 poster presentations at very important medical conferences at ASH and IMW, which is the International Myeloma Workshop. MCRN 002 was activated last year. This is a trial that we're working with a small biotech company out of Newton, Massachusetts called Karyopharm. And it's a brand new mechanism of action. It's a drug called selinexor. And thanks to the efforts of Dr. Chen in Toronto and Dr. Bayless in Calgary, this pretty much Canada is leading the global clinical development of this drug. We're currently in phase 1B, dose escalation studies, and they're combining this drug selinexor with either bortezomib, pomalidomide, or lenalidomide. There's 14 Canadian centers involved with this trial, and the recruitment is going very well. The biotech company is very happy. The third trial, which was just recently activated, is what we call the KCD or 003 trial, and KCD stands for Kyprolis, which is carfilzomib, cyclophosphamide, and dexamethasone. Again, this is for relapse and refractory myeloma. The initial idea for this trial came from Dr. Belch in Edmonton, and Dr. Chris Venner, his colleague, has taken the reins since then. What's important for this trial is, A, it does provide access to Kyprolis, a new drug, to patients with relapse refractory disease, but also it's looking at a different dosing schedule. Kyprolis was just approved by Health Canada in January on a twice-a-week dosing schedule, which, as we know, can be somewhat inconvenient for patients. So in this trial, we're looking at a higher dose, but given once a week, to see whether it's either as effective or even more effective than the twice-a-week dosing. And it combines it with a very accessible drug called cyclophosphamide, along with dexamethasone once a week. And I want to acknowledge the efforts of the local group, well, not the group based here in Kingston, the Canadian Cancer Trials Group, CCTG, whom we've worked in partnership to make sure that this trial goes through all the regulatory approvals, the contractual negotiations, and finally ends up being activated. And our first site was activated, I believe, 2 or 3 weeks ago in Quebec City. And this trial will be available here in Kingston. There are 3 other trials that are currently in development. They'll be discussed next week at our spring meeting with the CCTG. Dr. Seabag out of Montreal is working on the 004, Dr. Cepeda in Calgary, the 005, and Dr. Crary in Toronto, the 006. So you see the ideas are being generated from across the country, doctors and researchers working collaboratively to bring more trials to our Canadian patients. And I want to end again by acknowledging the efforts, the wonderful work that's done out of Kingston, Queen's University, with the Canadian Cancer Trials Group. Dr. Annette Hay has been very instrumental with the myeloma group in shepherding this last trial through all the bureaucracy that's needed to get these trials activated. And that's one thing I want to everybody understand. Getting a clinical trial to the patient is a long, very complex, arduous, bureaucratic process. It requires a lot of regulatory approval, ethics approval. So I sometimes wonder, it's a wonder at all that we get trials approved, but there's a lot of effort that goes behind this. So that's why we need to have this collaborative approach to make sure that everybody's piece of expertise is used to ensure that we focus on getting patients better outcomes. So that's it for my talk. I certainly welcome any questions or comments that you might have. Over here, Shanika.
My question is, why is it that there seems to be a little lack of communication between a doctor and a patient as to whether you're in a clinical trial? Because I'm probably in a clinical trial and have said all along I think I am, and I probably am because I'm taking Pomalyst with dexamethasone, and I think you mentioned that that's a clinical trial. I figure on my own it is because I took thalidomide, lenalidomide, and now this one. So I'm assuming when they come out with the newest ones, you're going to be in a trial, which I'm quite happy to be in a trial.
Well, it depends. Today, Pomalyst or pomalidomide is an approved drug, so it wouldn't necessarily be in a clinical trial. This is not to say that there aren't clinical trials of pomalidomide in different settings, like newly diagnosed, for example. I'm not sure which clinical trials they have right now. But just because you're on pomalidomide doesn't mean you're necessarily in a clinical trial.
The data is going places, though. It's traveling around. The information that comes from your treatment numbers, that's
if it's in a clinical trial, it's captured and
right.
It has to go into the database
right.
in order to evaluate all these statistics to make sure that it's safe, effective, measuring side effects, and whether what impact it has on patient outcomes, whether it's progression-free survival or overall survival.
Okay. Thank you.
With respect to drugs, the drug trials are one thing, but I find it kind of difficult to find out exactly, like say for in Ontario, what are the standard treatment options, or what drugs are available through the government. And it may apply to, all the provinces, I don't know. It's just nice to know what should be or what could be used, that's all.
It's a very good question, and not to dodge the bullet, but not that easy to answer. For example, I'll give you a very clear example. Officially, bortezomib is funded by the Ontario government. However, there are caveats. Basically, you can have it once, and as soon as you stop it, you cannot be retreated on it, like months or years down the road. So it's always a yes, but. And that's, to me, a very stark example where the other provinces fund it for retreatment, and Ontario, although it's listed on the formulary, it's funded. Once you use it once, the Ontario government, or whoever the decision makers are, have decided that, no, we're not going to pay for it again. In the case of lenalidomide, its indication is in relapsed myeloma. They've also had another indication for the use of maintenance, but they don't yet have an indication for frontline in newly diagnosed patients. There was results from a study that was done. Canada recruited very significantly into the study that showed the benefits of using Revlimid Dex as a frontline therapy for patients who are non-transplant eligible. And that's not funded yet. But the drug is funded, but it also depends on the indication or what stage of the disease the patient is at or what treatments they've had before. So it's becoming more and more of a complex kind of algorithm, if you will, to determine what the province will pay for. And yes, it varies from province to province, unfortunately. Would you care to add anything to that? Okay.
I just have one question. A thing that you mentioned, it's called the Myeloma Tissue Bank, and I've never heard of that. Is this something that all of us myeloma patients have had our tissue stored for research?
Well,
I've never heard of this.
You would generally it's through a consent, so you would know the doctor. Like I know at any other centers, if they're going to take your tissue sample to use for further research, they need your consent, so you would be made aware of that. But this is not unique to the center in Montreal. Toronto has a tissue bank, Calgary, Edmonton, pretty sure Halifax does. So it's not unique to one center. But you would be made aware of that. And I encourage you, if you're having bone marrow biopsies done, if the center that you're being treated at does have a tissue bank, to donate your tissue, or your bone marrow. Yes?
Last question. Sorry, too many. If you wanted to be involved in a trial, like for example MRD, I think that's an interesting thing. I'm living in Ottawa most of the time now. Is that possible to get involved in a trial in another city, like in Montreal?
That's another good question. Generally, you have to, if you're doing a trial, if you live in Ottawa, let's say, you're involved in a trial in Montreal, you have to travel to whatever city the trial is being held at. So yeah, it's possible. I know of patients who have enrolled in a trial in Montreal for a specific drug that perhaps that trial was not available in their center. So that is possible. Okay, then I think I've run a bit over time, so I thank you very much for your time and attention and your questions. Thank you.
Remember this moment. Aldo Del Col has a lot of fans, and I think I'm one of the biggest ones. It's a big fan club. There's not often in life that you meet somebody who genuinely has changed the world. And I'm not exaggerating here. Nobody knows everything, and Aldo has brought together all the individuals across Canada and beyond with their expertise in each different area, be it patient care, or be it what it's like to be a patient, or a pharmaceutical company who are making the new drugs, or a basic scientist who's working in the lab to identify new molecules. And he really has brought us all together He was mentioning collaboration. I think that's crucial to move things forward. So thank you, Aldo. So me, I'm Annette Hay. I know many of you in the room, and thank you all for turning out. It's been a great morning so far. Only short. There we go. So I'm Annette Hay. I was born in Ireland, travelled around like a bit of a gypsy. Then I went to Scotland, did most of my medical and haematology training there, spent a brief period in Brazil, and I came to Canada just over 4 years ago for 1 year. I loved it, and I haven't left. So you're stuck with me for a while yet. But half of the time, I spend treating patients with haematological problems, both benign and malignant, but definitely including myeloma. And the other half of my time, I spend designing and conducting clinical trials. So in all presentations, we're asked right up front to identify any aspects that might create conflicts of interest. So in conducting my clinical trials and designing them, I have received research funding from 4 different pharmaceutical companies. None of this has gone into my pocket, and I don't think it's relevant to this presentation. Over the course of the next 40 minutes or so, I just want to have a bit of an introduction and outline. What is a clinical trial? Why do we need them? How are they monitored and what oversight have they got? What good do they do? What trials are available right now in Kingston? And what might the future look like? And while it's on my mind, before I forget the last questions, we can go into more detail at the end. But if you are on a clinical trial, you will absolutely know, because you must be invited to participate. It's never assumed, and you must be given information regarding that trial and sign. And the same is also true for research specimens. So individuals are always invited and offered the opportunity to participate in research. It's not presumed. So here we start with the fantastic news, the past. So if you look at this graph, this one in particular is highlighting individuals aged 50 and under at the time of their original diagnosis of myeloma, and looking at their outcomes over the last 5 decades or so. So if you look at the very bottom line, the black one, these are people diagnosed in the 1970s. And when you look across, if you take that 5 line and follow it up and cut it across, so for those diagnosed with myeloma in the 1970s, at 5 years, around about 40% were alive. Move a decade up to the red line, diagnosed in the 1980s, around about half are alive at 5 years. If you're diagnosed in the 90s, we're getting about to 2/3. And if you're diagnosed in 2000, we're getting up to the quarter of people are still alive at 5 years. And this has been achieved through a lot of research, through clinical trials that enabled us to translate that research into how we treat people with myeloma. That was not me. And make a difference. So that's the good news. The bad news, or the opportunity that's left, is there still is a lot to do. Because when you look at the other curves for the other age groups, there still have been improvements, but as people get older at the time of their original diagnosis, the improvements have not been as good. And even if you look at the best case scenario curve, if you could, even for that best group, that's still a quarter of everybody who was diagnosed last decade with myeloma didn't make it to 5 years. So there is a huge amount of room for improvement to do better, and that's why we need clinical trials to continue those gains for individuals. So, and I'm going to keep my hands up here, there is a lot to be done. So question 1, why clinical research? There are lots of people working in laboratories, doing great work with their test tubes, their petri dishes, with small animals, mice. If we can see that a treatment works there, why don't we just use it and get it to patients? Now, much as women like to belittle men, I must acknowledge You're not. You're not mice. You're much more than mice. And there is a big difference between a mouse and a man. And just because cancer therapy works in a mouse does not mean that it works in a human. And here's an example. Now, this is an ovarian cancer example. But these are, on the left, mice with ovarian cancer, given an MMPI drug. And you can see those who got the drug had a big effect, a big difference in terms of increased survival in the mice getting this drug. On the right, you see how this drug worked in humans. No benefit at all. So this is why all of the important basic science work and the mice work is vital to identify those interventions that have potential for benefit in humans, but we cannot conclusively and reliably say it will work. So a clinical trial, it's a test of a new drug or a new treatment, possibly new radiation modality, possibly a new surgical intervention, or even a new diagnostic test. Something new that we think might make a difference. And before it is brought out to the general public, it is rigorously tested to be sure, does it work? Is it safe? Who's it best to use in? To document those results very, very clearly and accurately so that everybody can see them, and then so that the people who ultimately will have to pay for that test or that drug can be demonstrated that it's worth paying for. And there is a long and detailed research protocol developed. That's part of my job. You write these 100-page documents, or you use these 100-page documents when you're doing the studies, because you have to very clearly outline each step of the pathway. And we have to do them because we need to do better. I'm glad so many of you in the room are doing well. We want you to do better. So it's important to understand there are 3 different phases of clinical trials, because depending on the phase of trial on which you enroll, there are different risks and different expectations. So a phase 1 is the very earliest phase of clinical trial. So this is the stuff that's just come out of the laboratory. And really the important question is it safe? Is it safe in humans? What is the best dose to use? How should it be given? Should it be given into a drip in the arm, or an injection under the skin, or is a tablet okay? Or how often should we give it? Once a week, twice a week, once a month? And often in these studies, there will be a lot of blood tests, because blood tests are specifically done to try and understand more fully how the body gets rid of the drug. Is it metabolized in the liver? Is it excreted through the kidneys? And what time does it take for that to happen? Because all of that is important to guide the optimal schedule and dosing. Once you've figured out all of this, then you move forward to phase 2. Does it work? So you've figured out your dose, you've figured out your schedule. Now you'll get a group of individuals with a disease, give it to them at that dose and schedule, and figure out if it makes a difference. And then the third phase, phase 3. These are the largest studies. This is where you've got your dose, you've got your schedule, you've seen it works, at least in some people. Now you want to know, does it work better than what we already have, than our current standard of care? So in these trials, there's usually, in the first 2, phase 1 and 2, usually there's just one treatment that everybody gets. By the time you've got to phase 3, often at the start, when you enroll on a trial, there'll be what we call a randomization. It's effectively a flip of the coin, although our IT guys would flinch to hear me say that, because they put a lot of time and effort into designing the algorithms to randomly assign people to either the control or standard of care intervention or the experimental intervention. And this then enables us in an unbiased fashion to compare outcomes in the 2 groups and see if the new thing really is better or not. Sometimes these trials are blinded because we may all be a bit biased. And if you know you're getting the old one, you might not be that excited, and your doctor might not be that excited either. And it may actually influence how you feel about things. So often, it will be blinded, so you don't know, and your doctor doesn't know, which of these two interventions you're getting. And sometimes there is a placebo also. So, for example, you may get an injection of water or a sugar pill instead of the real thing. But you will always know this at the time that you're invited to participate in the clinical trial, because we must inform potential participants of exactly what are the potential outcomes. And before a clinical trial gets to the encounter in the patient room, with the room and the patient at the clinic, there usually has been years of work gone into it. So even when it's decided it's reached a stage ready to test in a clinical trial, we write the protocol, we develop the consent forms to be sure that everyone gets all the information they need to know to make the decision whether they want to be part of the study or not. Then this is all submitted to the Research Ethics Board. And every institution has a Research Ethics Board for all research that is done, and they are very rigorous in any research that is done on people for very, very good reasons. They go through this in huge detail. They will usually come back with questions and clarifications and sometimes recommendations for change, because it's their job to be sure that the research being proposed is justified and ethical and safe. Once we've got Research Ethics Board's approval, then the whole package is submitted to Health Canada, who again review in great detail every aspect of the protocol, the consent form, the way the study is going to be run, and often will come back with questions, clarifications, things they wish to be changed before they give permission for a clinical trial to be activated. So only once every single one of those steps has been passed is it possible to invite an individual to participate. And while the study is ongoing, because these are experiments, by definition, we don't know if it's going to work or not. That's the reason we're asking the question. There's an independent data safety monitoring committee who look at the data continuously, and even though we may be blinded and not know which treatment people are getting, they know. So if they see something not going to plan, they can change the course of the study and, if necessary, stop the study. So there is huge oversight to be sure that clinical trials are as safe as possible. And broadly, there are two groups of people who run clinical trials. The pharmaceutical companies are amazing machines and factories at producing new chemicals and drugs and testing them and bringing them forward to market for individuals to benefit from. So many studies are run by pharmaceutical companies. Their main goal, and I think it's fair to say, while pharmaceutical companies are definitely in it for the benefit of patients, they're also answering to shareholders. So they have two separate customers, two separate groups to answer to. My role is with an academic clinical trial cooperative group, where we're asking similar questions, very definitely the same goals to improve the lives of people with cancer, but from a more scientific, academic perspective. We're not answering to stakeholders, we're trying to improve the lives of individuals. And often very large cooperative groups are established so you can get the expertise involved from everybody to address the best questions and answer them as quickly as possible. And this is the reason I'm in Canada. So the Canadian Cancer Trials Group, you may or may not have heard of, but Kingston's kind of a big deal, because this is the hub for the entire cancer clinical trials network across Canada and the world. So since its inception 36 years ago, the Canadian Cancer Trials Group, which was previously called the NCIC Clinical Trials Group, has conducted 510 phase 1 to 3 clinical trials. Over 80,000 patients have enrolled on these studies, and many of these have changed the way patients are treated, both in Canada and around the world. And the Canadian Cancer Trials Group addresses questions in all cancer types. Myeloma for sure, but also kidney cancer, brain cancer, all sorts of cancers, and also all the different treatment modalities, surgery, radiation, and drugs. The Canadian Cancer Society give us a generous grant. It is the largest grant they give out each year, and they recognise that this grant results in the greatest direct benefit to patients through the work of the Canadian Cancer Trials Group. And it's quite nice among everyone else here, a couple of my clinical trials colleagues who, so I do the talking, they do the work and make it happen, are here. So Kingston's the hub. Kingston makes it happen, but you need the network. So we have over 80 member sites in all provinces across Canada who participate in these clinical trials and make it happen. And beyond that, the Canadian Cancer Trials Group has led clinical trials in 44 countries around the world in 5 continents. That's all in Kingston, 10 Stewart Street, just down the road. And while the mission of the group is to conduct clinical trials to improve the treatment and prevention of cancer, to reduce the burden of disease for individuals, within the vision, we also see it as very important to contribute to the sustainability of the Canadian healthcare system. I think it's one of the great things about Canada and the UK is the equity in access to drugs. But we all know that drug costs are rising. We need to figure out the best way to take the drugs that are available to make use of them for the biggest number of people to benefit. So much like support groups, as came up in the last conversation, clinical trials aren't for everyone either. There are risks and benefits. There may not be trials available for every individual, and an individual may make an informed decision that they don't want to be part of one. So the potential benefits, it may offer access to new emerging drugs. There often is a period where a drug looks really exciting as it's coming through clinical trials, but there's not yet enough information for a funder to make the decision, yes, we're going to pay for that. So in some cases, participating in a clinical trial may give you a chance at having access to a drug that looks promising. The flip side to that is, if you are in a randomized phase 3 trial, and it's key that we do that proper test to see if it's better, you may be randomized to the control arm anyway. So even if the goal is to access a new drug, everyone must be aware there's a chance you'll still be accessed to the current standard of care. For some people who may be nearing the end of their disease pathway, where they have exhausted all the funded drugs, all the available drugs, some people want to keep trying. And a clinical trial perhaps offers a glimmer of hope. There's something else to try. May or may not work, but let's give it a shot. Undoubtedly, while you're on a clinical trial, you get really attentive care. Now, I know there's lots of the nurses here anyway that you know anyway, and you know these guys are good. Once you're on a clinical trial, it moves to a whole higher level. Then you meet the clinical trial nurses as well, and there's a group of them. Stephanie Willing is the one I work closest in, but there is really close attention to care, partly because we need to document your experience completely and exactly so that we can portray that and inform future practice. There's also the opportunity to advance science, contribute to developments for future patients to benefit from. And I think that's one of the big ones. The risks. It is a trial. By definition, we don't yet know if a trial's drug will work. You may get more side effects. You may need more tests, more blood tests, more x-rays, possibly more bone marrows. You may need more clinic visits. And the drug or the test might not work for you. Even if it works for others, there's never a guarantee it'll work for you. So this is a real balance, and everybody has different comfort levels with where they wish, the risks they wish to take for potential benefit. And this will be different for every single trial that runs, where the risks and benefits differ depending on the study design. I think the key is whether or not as an individual you benefit. It definitely informs future practice and offers potential to help future patients who come after you. And it's really interesting. None of us quite understand how this happens, but it's repeatedly been shown that individuals overall treated at a centre that participates in clinical trials tend to have better outcomes than those treated in institutions that don't do trials. Why? Who knows? But it does seem to be one of the benefits of being treated in a clinical trial institution, even if you yourself are not participating on a study. So, anyone know this road? It's the 401 on a bad day. Because Toronto, Princess Margaret Hospital, fantastic places. They have around 8 trials open right now for people with myeloma. But who wants to drive there every week to be part of a study? If you need to, great. But what we really want to do is bring more trials to Kingston so there are more opportunities for individuals here. So right here in Kingston again, at Kingston General Hospital, we have the clinical trials unit locally. There's a team of 9 staff led by Tracy Hanna, who's the manager. And right now there are 36 clinical trials open for patients with cancer in Kingston General Hospital. 3 of these include patients with myeloma. And we are rapidly growing. There have been a lot more open this year and a lot more anticipated to open in the very near future. So I just wanted to give you a brief introduction to the 3 studies that may be available and may be of interest, available at Kingston, as examples of the research that you may be interested in participating in. So this is the one that Aldo alluded to, MCRN003 or MYX1. We really don't do a good job at making these titles catchy, do we? But this is the study. So it's a single-arm phase 2 study of weekly carfilzomib plus cyclophosphamide and dexamethasone. And this is being conducted by Myeloma Canada and by the Canadian Cancer Trials Group. So carfilzomib, some of you I know have heard of it. It's a new drug, a new proteasome inhibitor. So it's like bortezomib, like Velcade, looks like it might be a little bit better. And in previous studies, it's shown that it is active against myeloma, even in people who've had lots of lines of treatment. And usually, as Aldo said, it's given twice weekly. And in this particular study, we're looking at a different schedule. Previously, in one of the recently published studies, carfilzomib was given with lenalidomide and dexamethasone. The hypothesis of this trial is that giving carfilzomib once weekly may be a lot more convenient for patients who are getting it. It probably is still going to be very active against myeloma, especially with the addition of 2 other drugs, cyclophosphamide and dexamethasone. And it's going to be way more affordable for the Canadian healthcare system than a combination including lenalidomide. So the inclusion criteria for this study, and the inclusion criteria is always a long list that you have to go through to check, do you meet the criteria? And there are reasons for the criteria. So this trial is for people with relapsed or refractory disease. So that means you've been treated once and it's come back. You have to have had at least 1 prior treatment and up to 3. And you need to have measurable disease. So what that means is your monoclonal protein level higher than 5, or a plasmacytoma, a solid tumour that can be measured. And the reason for that is, over the course of the study, you need to be able to measure if it's working or not. So you need something to be able to measure. For safety, need to be sure your blood counts, kidney and liver function is good enough and it's safe to administer these drugs. And for this trial, because it's testing carfilzomib, you can't have had carfilzomib before. The dose and the schedule. So carfilzomib is given as an intravenous drug. Cyclophosphamide and dexamethasone are given orally. And this study will accrue 76 patients. It is just getting started, and Gail, sitting in the middle at the back, is the one who's making it work. It's just opened in Quebec. It should be opening in Kingston in May. So it's a potential option. These lot did a better job at naming it. The AVERT trial. Now this is an interesting one, and this idea came from the Ottawa Research Institute. Because while yes, it's very important to identify new anti-myeloma drugs and improve outcomes through doing that, there are also a ton of other important questions. Things like improving pain control, improving quality of life, improving anti-sickness drugs, or this particular study is asking the question, can we reduce the amount of blood clots happening? This is a phase 3 study, randomized, placebo-controlled, double-blind. Open right now, as of a couple of weeks ago. So this is based on the premise that we know that people with cancer have a higher risk of getting blood clots, which can be either in the leg, a deep venous thrombosis, or in the lungs, a pulmonary embolus. This is pretty inconvenient. At the very least, it's usually painful, it can cause swelling, can cause breathlessness, and in some circumstances can be fatal. So clearly, something one wants to avoid, and we know the risk is highest while you're on chemotherapy. However, taking anticoagulation, while it reduces your risk of blood clots, it also increases the risk of bleeding. So for each individual, one needs to find the right balance between the risk of thrombosis and the risk of bleeding to be able to make an appropriate recommendation to try and prevent blood clots. So this study is asking the question about apixaban, which is one of the new anticoagulant drugs that is already used routinely for people with clots, looking at in patients who are receiving outpatient chemotherapy at high risk of blood clots, can taking this drug prevent blood clots? And to be included in this trial, either it's for people with newly diagnosed cancer or those in whom it's come back and they need to start new treatment. Your platelet count has to be at least 50. That's because a platelet count below 50 increases your risk of bleeding, so it may not be safe to go on the study. And again, because the drugs are excreted and metabolized by the liver and kidneys, your liver and kidney function needs to be good enough. Now, there are some people at high risk, very high risk of blood clots. So if you have an irregular heartbeat and need warfarin or another drug anyway, then this would not be appropriate because we know for you need anticoagulation. There are other people for whom the risk of thrombosis is so low that taking anticoagulation and the increased risk of bleeding wouldn't be worth it. So they also would not be included. And they're deliberately trying to identify the middle group, in whom we really don't know how best to balance it. And there's a scoring system to try and broadly ascertain someone's risk of thrombosis. So myeloma being most relevant to this group, you get 1 point. You would get another point if your platelet count was over 350, or you were on erythropoietin, or your hemoglobin was less than 100, or your white cell count was over 11, or you were overweight with a body mass index of over 35. And if you score 2, then you are considered an appropriate risk group for this study. It's really very simple design. It's quite beautifully done, actually. So at the time you are identified as eligible, if you wish to participate, then you are randomized either to placebo or to the apixaban. You won't know, we don't know, but the people conducting the trial will know. So when the results are reported, it will be very informative. And the follow-up is minimal here, at routine visits anyway, or via phone calls. The information they want to gather relates to bleeding. Did you bleed? Relates to blood clots. Did any happen? Other medications you're taking. Quality of life. And I actually haven't highlighted that enough. While yes, we want to extend the duration of people's life where possible, we also really want to focus on improving the quality of life. So that is a key component of many clinical trials. And there is also a blood sample taken to check how the drug is metabolized. So this is now open in 8 centres across Canada. So far, 177 patients have been enrolled out of a total of 574. So that's an option. And the third one, very quickly, we have already been enrolling to in Kingston, PHL-091, another catchy name. This is a phase 2 study coming out of the Princess Margaret Hospital in Toronto. It's on hold at the minute, and that was planned because there is an interim analysis on right now. Everyone got that? Because I haven't. I've just put this up to give you a flavour of how complicated myeloma is. I don't think anybody understands all of this. But very broadly, it's giving you a representation of the multiple different molecular pathways that are involved in giving the tumour a chance to expand and grow and survive. And one of the ones up at the top left, you'll see there can be mutations in NRAS, KRAS, BRAF. We know that these mutations can cause cancer. And while many of our old treatments have been generic, they've just targeted rapidly dividing cells, now we're moving into an era where we're developing drugs that target specific abnormalities, so BRAF mutations or NRAS mutations. So this particular study is looking at trametinib first off, which is a MEK inhibitor, so MEK being right there in the middle on the left. So that's part of that important pathway. And we know that in patients with melanoma, skin cancer, there are often BRAF mutations, and the curve on the right is showing you that in melanoma, the skin cancer, trametinib has been really good. So, based on that, trametinib has been introduced as standard of care treatment for patients with this type of skin cancer. And it's logical, given that we know BRAF is often mutated in myeloma, that it might work there too. The second thing that's added into this study is an AKT inhibitor, again, in the centre, trying to look at if we add another drug that blocks somewhere else in that pathway, do the two together work even better? Because the laboratory studies have suggested they might. Now this, for all it's just everybody gets the same treatment, this is a really complicated study. To get into it at the very start, you need a bone marrow. The specimens go to Toronto, where they look to see in your bone marrow, does your myeloma have any of these mutations? And the point we're at right now is the second line down. So 12 patients in each cohort have been enrolled, those who had the mutations and those who did not. So there's been a hold put to accrual so they can look in those first 24 patients and see, is it promising enough to carry on? So the primary question is, does trametinib work in myeloma? And the secondary one, does the addition of this GSK2141795, that's how new a drug it is, it doesn't have a name yet, help? Again, neither you nor I are expected to know all of these. My point here is, this trial is intensive. There are extra bone marrows, there are extra blood tests. We all really hope these drugs work. But even if they don't, a huge amount of knowledge is going to be gained from this study, because they are doing many, many basic science tests to try and understand more about myeloma, to try and identify, within this study we've already seen, it's working for some people, it's doing nothing for others. So looking at the type of the myeloma, can we try and figure out for whom it works, so that in the future perhaps we could direct it to the right people? So on pause right now, may reopen in the near future if it passes the first stage. And the future, who knows? But the future's actually pretty exciting right now. There is so much going on in myeloma. First of all, we've got so many new drugs in the last few years. We need to learn a lot more about what's the best order to give them in. So many trials right now are being designed to ascertain which should come first, the lenalidomide or the bortezomib, or should they be given together? New combinations. Again, you've seen in the MCRN003 study, we know carfilzomib looks as if it works now, but could we give it with other drugs to make it work better? And for all the new emerging drugs that are coming through, some of which Aldo alluded to in his presentation, are they safe? Do they work? And how best can we use them? And so next weekend, many of us in the room will be spending it together again in Toronto as we are bringing everyone's heads together to try and design the next phase of clinical trials to answer these questions. Other things, measurement of circulating tumour DNA in blood. This is pretty exciting. And this is Suzanne Trudel and others are working on it because perhaps we can get much of the information we need about the myeloma in the blood and reduce the need for bone marrows in future, which I'm not a huge fan of doing them. I bet you're even less of a fan of getting them, so that would be great. And some of you have heard the conversations. So Vincent Rajkumar in the US and others have started to ask the question, we've improved survival so much in myeloma, can we take it a step further? Can we cure it? And he said, within 5 years, he thinks we can. So I like the challenge he set. I think the jury's out on whether or not that's feasible, but it's a great challenge to set ourselves. And some people, as Dr. Matthews alluded to, are suggesting that giving more treatment right from the start, higher intensity, and for a longer time might reduce the myeloma burden enough to cure it. Right now, nobody knows, and that's why the trials are ongoing. But these are some of the questions we will be answering in the future. So thank you very much. I'm happy to take any questions. Oh, he asks the hard ones.
I don't know if this is hard or not. It's not clear to me the drugs we're talking about or you're talking about in these trials, are they intended to be applied on a continuing, ongoing basis just to sort of suppress the myeloma? Or are the objective here is to get the complete cure, put you in remission as a stem cell transplant would be for a certain number of years? So I don't know if I'm clear on that.
Yeah. So the 2 myeloma studies I mentioned there, in both of those, the intention is to continue on the drugs for as long as they are working and the side effects are not too bad. So the intention of these studies is not cure in these settings, but to control the disease for as long as possible. And the question you're alluding to is important because what we learn in this setting then perhaps can be taken forward in the future into the frontline setting where it may be even more efficacious.
How do you find out about these clinical trials?
Good question. So, when you're at your hospital appointment, you can ask what trials are available, and I would encourage you to ask. Also, 2 of the websites I've got here, Myeloma Canada has an excellent link on its webpage to clinical trials, and that alerts you to potential trials and where they are open. There also are various web pages where you can find that often not that user-friendly. That's something we're working on. But these 2 sources will allow you to search for open trials for myeloma and identify where they are open.
Great. Okay, everyone, maybe we'll give Vanette a round of applause. Okay. Okay, so we're almost at the end of our morning, and I just wanted to thank all of you first and foremost for coming today. I know many of you traveled from hours away to be here, so it's really an honor to have everyone together in this room. I talked to a few people during the break, and they said that they found this empowering to be able to see other people who are going through a similar experience and to learn from our experts about myeloma background and what's coming in the future. A couple questions during the break that I wanted to answer. One person asked, a few people asked whether this is being recorded and whether it will be offered on the website. And yes, once the Sam, the IT person at the back, who I also actually want to thank for being great to be our IT support. He will be providing the recording to Myeloma Canada, and it's my understanding Myeloma Canada will be offering it on the website. So maybe give the website a couple weeks and then return to it, and you'll be able to actually see the videos to recall any of the information from today. Also, Leslie's presentation stimulated some conversation around the possibility of starting a support group in the Kingston area. So what we'd like you to do is, if you are interested in joining or leading a support group in Kingston or any other area in our region, the contact information for that would be to contact Myeloma Canada, and their details, I believe, are on the materials you've been provided today, but the email address is contact@myeloma.ca. So they will collect those responses and sort of work with us here in Kingston to see if we can help support that. And primarily the nurses in the stem cell unit, so Julie, Angie, and Nancy, I think are interested in helping get that going and supporting you to sort of roll that out similarly to the way that Leslie was able to do it with the nurse manager in Coburg. So just giving you that information. So again, I just wanted to thank you. I really wanted to thank the speakers and for the volunteers that were here coming on a Saturday to spend time with us. So I don't know if anyone from Myeloma Canada wants to say anything else, but I think that's it. And you're welcome to hang out and chat a little bit more if you want to talk to anyone else. And yeah, thank you.
Well, I just wanted to echo our thanks for the group here in Kingston for helping facilitate putting this info session on. I'd like to thank Shanika in the back, who's a tremendous help as well, and Sammy, of course, for the wonderful IT work, and most importantly to all of you for coming out today. There's a lot of hope out there, so hang in there. Thanks again, and we'll see you. Hopefully see some of you at our national conference in Montreal next month. Take care and happy travels.